Hello, good morning. The registrar, facilitator in the name of Professor Samsi Ebeneme, his assistant, Mr. Fatai. So, welcome to the first edition of our lecture series on Monday, Tuesday, and Wednesday. That's the hands-on part. Today is going to be the virtual part. As we promised, it is going to be live stream on YouTube so that whenever someone wanted to go back and check something, so you can easily find it. Even if there is no link sent, you can just search for clinical pathway. You will see so many series of clinical pathway workshop. Just look at the one you want to watch over or do you want to go over again. So just click on it. It will allow you to watch. Thank you very much. I don't know if the registrar is around. So if you will say 1 or 2 words, the registrar, sir. Okay, I think the registrar is not here. Uh, Mr. Fatai, I don't know if you want to say something before Prof start the lectures. Over to you, sir.
Good morning, everybody. Good morning, the registrar in absentia. Good morning, profs and senior colleagues. I have nothing to say for now, but during the course of the lecture, I might say 1 or 2 things. Thank you.
All right, good morning, everybody. Thank you for joining us today in this spectacular session where we are poised to look at movement sciences in its totality. As much as the time and the program design can allow us, it has always been my passion to unlock this virgin area for physiotherapists, which we should be able to leverage, and for other colleagues in the rehabilitation sector in order to make our patients recover faster and drive our clinical decision making utilizing clinical reasoning. Expertise is actually 90% of clinical reasoning before you can think of other aspects of practice. Because if you really don't get the reasoning right, every other thing will go wrong. And most of us over the years have acquired competency and skills necessary to make interventions. But are we making the right intervention? Yes, because what informs our intervention is the clinical understanding of movement sciences. And therefore, clinical reasoning becomes very, very key. And this is an aspect in Nigeria we see a lot of challenges. And I want to thank the registrar who have deemed it very important that physiotherapists, occupational therapists, and other colleagues in the health rehabilitation sector come together to acquire some skills and competencies in this area that will drive their management. I'm going to be discussing movement sciences from a very critical angle. Over the years, the way movement sciences, including biomechanics, kinesiology, clinical gait analysis, has been taught, creates the impression of an abstract ideation, as if it is something that is so abstract, something that is so far away, ideas that are conjectured in the realms of advanced engineering and modeling and so on. And that makes people to lose interest and not understand the relevance of it. But I don't also blame individuals who feel this way, because you have movement sciences that are applicable in biomedical engineering, that are applicable in all aspects in physics. Movement sciences applicable in physiology. There are movement sciences applicable in other physical sciences. And everybody will teach it from the perspective and through the professional lens. The challenge we have is that because physiotherapists seem to be like latecomers to this area, you see that even in physical and health education, they teach it, but the perspectives are different. A physical and health educator will teach it from the perspective of sporting activities and enhancement of performance, and understanding injuries and injury prevention, and possibly, leveraging the body as a lever system to accomplish the goals of each sporting activity in a more efficient and effective way that enhances performance and then advances their interest in realizing the trophy and so on and so forth. But it is rare for anybody to teach it as a clinician. And so, because some of these other areas are more well developed than that of the clinical services, we battle a lot, and then we don't really utilize it in the clinics. Whereas if we do, it could be a money earner, but that is not even it. It will enhance our practice so much that other professionals will seem to also respect what we do, because it provides a scientific basis for our intervention and scientific basis for our decisions and diagnosis. And so this is why this is very important to me. And I wish that you will also, pay attention and walk this journey with us. I want to state outrightly that for me, my understanding of um, a facilitator is not an expert. My understanding of it is someone who is willing to help others and help himself also to learn. For me, I'm also here to learn, because among us we have very experienced experts who have, done so much in this field. And so I'm learning as well. I will only give my humble opinion in some areas. I may be, don't see me as an expert who knows it all. No, I don't. I'm also learning, and I'm here to learn with you and to walk this journey with you and to give you sometimes my perspectives about these things, and then also learn from you. So feel free to draw my attention anywhere you have a need to further explain and so on. And please, you can drop questions, you can drop comments in the WhatsApp and in the chat room, in the chat box. And I'm thinking that the MRTB will bring that to our attention, and we will deal with that. I'm segmenting this into 10 modules, and I will try to see if we could finish. I want to say ab initio that do not mind my language. I will be speaking the language of movement science. Every specialty has a language, so I will be speaking that language unintentionally. Intentionally, because this is what I've been doing. So sometimes it becomes part of me to say these things that way, because that is how it is expressed, within the specialty cycle. But pardon me, if you don't understand it, please draw my attention, the chat box or chat room. I will be able to break it down, try to see how I can slow down. Sometimes I may say that unknowingly. But these languages are nothing technical. They're nothing. You just may expression that lies within the specialty. Just like in your various specialties, there are also very typical and specialized languages which you are also used to. It is just the same thing. So, having said that, I will zero in to start with our module 1. And our module 1, we shall be looking to understand why we are here. what exactly it's all about. We are taking a look, as it were, at biomechanics, movement sciences, and I'm going to outrightly speak to biomechanics and exercise, and kinesiology of exercises generally, because exercise is the core of movement. And then I would zero in more on when we interact on Monday on clinical gait analysis and movement pathologies, and then prepare you for the hands-on workshop on Tuesday and Wednesday. I'm going to bring this part because this is the critical part behind movement. And if you don't understand this, and I jump in and I start teaching you movement and teaching you, behind gait analysis, and if I start teaching gait analysis and you don't have this background information and understand the connection, then it's going to be difficult. You just get to know the concepts of gait analysis, the concepts of Kinovea, the concepts of velocity field diagram, and so on, but you will not know the basic sciences, movement sciences behind them. It becomes difficult when you are going to deploy clinical reasoning in certain areas. So I just want to, talk about the um, biomechanics and kinesiology of exercises, and then we look at certain contents that are relevant in this area. All right. I will start from the basic. Whenever you hear about movement, possibly the most important thing that comes to us is translating from one point to the other. But today's session, I'm going to lay the foundation, the mechanical foundation for everything we do in clinical rehabilitation. Because everything we do in clinical rehabilitation revolves around form and function, revolves around movement, and movement is central to that idea. But there is something very central and key to movement. Our central argument is simple. Rehabilitation becomes more precise, it becomes more defensible, it becomes more effective when we understand movement in the terms of force, in the terms of torque, in the terms of lever system and load management, rather than in terms of exercise labels alone, which is what we all do all the time. So the basics of movement actually derives from force. You need to understand the force, how this force is generated, what is implied when it is generated, and then what is the turning effect of the force when it is generated? How is the body leveraging its structure to generate these forces, and what are the consequences of changes in the structure of the body as a lever system? And then gaining insight into the management of load to even know what load means. Because when we talk about load, many of you think and believe that load only happens when you carry weight. You are correct. But when you talk about loading in the terms of biomechanics of movement, we are talking about force generation. Any activity that generates force, that compels the system to generate a force, is actually loading the system. So whenever you hear loading in movement sciences, it means that the system is being compelled to generate a force internally or to resist a force externally. So loading is a common phenomena in activities of daily living. And so we are going to harness all of this in order to gain insight into everything we do in movement, including in exercise prescription. And when we don't have that basic understanding, then there is a problem. It is also going to be impossible to understand movement dysfunction without also understanding these bases. So this module one slides simply frames force as the basic body weight. When we talk about anything that elicits the body to contract, the muscles to respond, one of them, can we be muted? I don't know, MROTB. One of the things that compels the body to actually respond to load, to respond by loading the system, by generating forces, is the body weight itself. So even as you are, your system is loaded by your body weight. And one of the things externally challenging you, in addition to that, is the force of gravity. So every day of our life, within the gravitational force field, our muscle, our motor system, our musculoskeletal system, our locomotor system is always loaded in one way or the other. But it will change depending on our position, it will change depending on our activity, and also other patterns applicable to them. So in this first module, I am framing force as the basic mechanical input in rehabilitation. It arises from body weight, from gravity, from external resistance that we get from the environment, and from the ground reaction force. And many of you may not know about this, but we're going to discuss it in a way that you understand that ground reaction force is critical in shaping everything we do in movement science. And they emphasize that its effect may be therapeutic, it may be harmful, depending on magnitude, the direction, and control. The very effect of force may be therapeutic. The very effect of force generated may be harmful, and the very effect of force generated may vary. Either way, beneficial, therapeutic, or harmful, depending on the direction of that force, depending on its magnitude, and the control system exerted by the body, either our patient or the therapist, because we can exert all of this. We can alter all of this. For us in Nigeria, this discussion is especially relevant because, you know, many of our rehabilitation decisions are still made in environments with constrained technology in the rural areas, or in environment where we have variable staff, where we have high patient volumes and limited resources in terms of equipment to deal with them. In such settings where biomechanical reasoning is not optional, it becomes mandatory that we are properly equipped. Because even though we may not have the equipment, even though we may have poor staffing, then biomechanical clinical reasoning will no longer be an option. It has to be mandatory. And that is a recognition that the registrar and the board has brought, into this. That is why they convened this workshop. And he has been he's been in touch with us to make sure that we deliver this and to, train very competent experts in this area that can, grow this field nationally. And I think it's a lofty vision, and I thank you for buying into it. So it is our portable instruments that we have, our portable instrument that is available to us in very limited resource setting is our clinical reasoning. Because with it, we can change everything, even though we don't have the infrastructure. We can make significant impact, and you are going to see it demonstrated over the course of these several days of the workshop. So I believe that this is a movement in the right direction, and we are going to utilize biomechanical clinical reasoning as a portable instrument where advanced gait laboratories or force plates are unavailable. Then the clinician's understanding of force, our understanding of movement mechanics, becomes the most important analytical tool that we have in the room. I was in South Africa Cape Town precisely in December 2024. Yes, in 2024. And I was met, I spent good time, for, I think a week or so, 2 weeks with them at the CISA Center in University of Cape Town. I was quite amazed. They developed a force plate, what we would call in data analysis a workflow. Workflow is a 10-meter, station where you have the platform or the ground embedded with sensors. We call them force plates that are designed to measure the forces you exert on the ground when you walk, and also the forces the ground exert on you, which we call the ground reaction forces, because action and reaction are equal and opposite. And, ordinarily, they did something fantastic and amazing. I met Yumna, who is the director. Yumna is a fantastic lady. And you see, a first plate of 1 square meter, just like a tile, just like maybe 4 tiles put together. 1 square meter is, I think, is roughly about $100,000. So when you have a 10-meter workflow, you are talking about $100,000 times 10, about $1 million, just to create a 10-meter workflow. You see, in naira, that should be close to maybe 135 million naira, just for a 10-meter distance. You see how challenging it could be. But then, even when we do not have all that resources, we can utilize our clinical reasoning as a portable tool that can change the dynamics of things. And that is why this is important. Because even in the absence of these resources, we can utilize knowledge of what we know, the basic science of force, of moment, and all that are associated with that to make very insightful and accurate clinical reasoning outputs that will guide and undergird our intervention processes, diagnosis, and prognosis decisions. Now, the aim of today's lecture is to show all of us that core mechanical principles can be translated into clinically useful decision-making processes. Specifically, we will examine force as a vector in this module 1, then the meaning of torque and the moment arm, the distinction between internal and external forces that we always experience every day, and the role of lever system in human movement, and then the clinical relevance of work and power, because these are all phenomena of interest in this direction. They are important concepts. And the slides you see now, they present these ideas, not as abstract physics, no, that we are used to, but as the basis of modifying movement difficulty, or the basis of understanding, interpreting compensations that we see in the clinics among, within the patients, and the progressing and the regressing of exercises in a scientific manner. So this information, this way we will frame it and relate it to the clinical processes, will make you understand its relevance and not just an abstract ideation that is applicable in realms of physics and physical sciences. They are the basis for everything and fundamental movements we make in physiotherapy, management of conditions, or in the rehabilitation sector generally, beyond physiotherapy into occupational therapy and other therapies that are applicable in this area. First, I want to look at force as a starting point of clinical biomechanics. Now, we begin with the most basic concept, and that most basic concept of clinical biomechanics and movement is force. The slides that you are looking at, they define force as push or pull measured in Newton meter. And that is one important aspect that is critical. We always see force as push or pull, and that is correct. And the stress that force can either produce motion or deform a tissue. That may be different from what you know what you think now. Because all we know is that force is push or pull. But we go furthermore to look at it that that force can produce emotion, which becomes therapeutic, or it can deform a tissue, which may be antithetical to what we want to achieve. Then we need to know all of these. So in rehabilitation, this is the language of loading. We look at loading as what can either produce motion or what can deform a tissue. Remember, loading is the generation of forces from the structural components of the locomotor system in the body, which entails deploying the muscles, deploying the skeletal structures, the nerves, the ligaments, the cartilages. They all come together and they are melded into a low-dimensional deterministic machine. And so when we speak about force, we are speaking out of something that can either produce motion or deform a tissue. And if you understand that, then there is a caveat in its application. And there is also a caveat in the clinical reasoning about the whole process of movement and even in exercise prescription. So every transfer that we make, the patient make transfers from bed to chair or from the chair to the bed. We can help them to do so, or they can do so unassisted. But every transfer we make, every step we take, every resisted movement, every manual handling task, and every therapeutic exercise that we always implement is a force problem before it is anything else. So you cannot divorce force from these activities. So when you are handling a task, when you are manually, handling a task with the patient, when you are prescribing and supervising transfers from sitting to standing, or from a chair, transferring to a bed, or so on and so forth, every resistant movement that you create, every manual handling task that you implement, every therapeutic exercise is actually a force problem. You must see it as a force problem, which you need to actually find a critical balance and think through. Don't see it as anything else. That is what it is. It is going to be a force problem to you as a movement scientist before it can become anything else, because force is fundamental to all of them. Remember, force can either produce emotion or force can denature a tissue. It can deform a tissue. So as expert clinicians, we already observe functional difficulty every day in the clinics. A patient struggles to rise from the chair. A patient struggles to climb a step. A patient struggles to control descent from a step. A patient struggles to stabilize the shoulder. But mechanically, each of these difficulties actually reflect one thing. They reflect a mismatch between the external force demands and the internal capacity of the patient's neuromuscular system to manage those demands. There is an external force demand that is required to accomplish these activities, but the internal capacity of the patient's neuromuscular system to manage these force demands is the issue. And that is what we need to address. And that is the angle and perception that sometimes are lacking in our dealing with these cases. And sometimes it may undermine the eventual outcome. So that is the major message for today. That when function fails, we should first ask what forces are acting here, and how is the patient responding to these forces. That is what we should be asking. Anytime any function fails, what forces are acting here? And how is the patient responding to them? I don't know if you have thought about it this way before when dealing with your patients, especially when their function fail, or when they present to you in the clinic with failures to function properly, and especially in different activities of daily living. And as you are assessing, are you asking yourself the question, what forces are acting here? And how is the body, how is the patient responding to these forces? What are his internal capacity to manage or control these forces? Because the capacity of the patient's neuromuscular system to manage or control these demands, these external force demands, is the critical part. And that is what demands our intervention. So in the practical Nigerian rehabilitation setting, force sources are often ordinary and familiar, but they are hardly captured in our analysis, captured in our clinical clocking and assessment of the patient. Body mass during sit to stand is an important force source. Ground reaction force during gait or walking is an important force source. Gravity during limb lifting, either lifting your limb to carry an object away from the body or towards the body, is an important force source. Or the therapist that applies resistance during strengthening is an important force, source. Yet, you see that their effects vary enormously depending on alignment of the body, on the posture of the body, on movement strategy adopted by the individual, and the tissue tolerance of those forces. And these are things we hardly put in perspective when we analyze and when we assess. This is why two patients performing the same exercise may not actually be performing the same mechanical task. That they perform the same exercise does not mean that they perform the same mechanical task, because their ability to perform the same mechanical task will depend on what is their alignment, body alignment. What is their posture? Are they different? Are they the same or different? What is their movement strategy? Are they compensatory movement strategy? Are they normally aligned movement strategy? And then what is the tissue tolerance of the individual based on the existing and underlying pathology that the patient has experienced? So you may prescribe the same exercise, but you have not prescribed the same mechanical task. This is where the physiotherapists and movement scientists and occupational therapists and other therapists in the rehabilitation sector get it wrong. They will always think that performing the same exercise is performing the same mechanical task. It is not. Therefore, it means that before your patient can perform an exercise, there must be an intentional decision about the mechanical task. And you cannot make that decision if you have not, first of all, determined the posture, determined the alignment of the body, determine the compensatory strategies that exist in that situation, and have an insight into the tissue tolerance. Otherwise, the intended exercise you have prescribed may not match the mechanical task that is desired. And if I bet you, if you take a look at your assessments in the last 1 year, 2 years, 5 years, especially before you prescribe exercise and prescribe movement rehabilitation, you will see that you may never have conducted body alignment assessment, postural alignment, postural assessment, and connecting these assessments to the mechanical task that is desired in terms of force, production that can either bring about motion or deform the tissue. The second thinking I want to also explore under this is I want you to know, which is the second critical point, that force must be understood as a vector. Many of us have done this in the school. We know the vector quantities and the scalar quantities. But I want to bring it in a different dimension in the clinical sciences. Remember, if you look at the slide desk, the slide deck you are looking at now, it correctly emphasizes that force is a vector, which is correct, which means it has both magnitude and direction. This slide deck you are taking a look at also notes that a change in direction of the force can shift the tissue stress from one structure to another. For example, you can either shift the change in the direction of a force from compression towards a shear force, which may be riskier for ligaments and other vulnerable tissues in the body, especially when dealing with your patients who has compromised neuromuscular system. Because remember, force can either generate motion or deform the tissue. But remember that forces produce two key directions. They are either shearing. When you hear about shear, S-H-E-A-R, it means to tear apart. They can shear the tissues, they can tear them apart, they can tear the joints or distract the joints. They can also compress them together, squeeze them together. But which one happens and when? And I'm trying to say that you must lay emphasis that force as a vector means that it has both magnitude and it has direction. The implication of that is that when we change the direction of a force from one structure of the body to another structure, quickly the effect of that force may switch from compression or compressive or squeezing the body structures to tearing the body structures apart. So it depends on which direction the force acts on the specific body part. But when we transit from one body part to the other, that same force that was squeezing it together in one part may be tearing it or distracting it apart in another area. So it means that you need to think it through when you try to deploy these forces in your intervention, because they have consequences. They can bring about compression and move from compression towards shear, which may be riskier when you go towards shear. Once you go towards shear for ligaments and other vulnerable tissues, it means that they will definitely be deformed. That may not be your intention, because your intention may be to generate motion that is sufficient to restore the body to form and function and sustain activities of daily living. But the moment you move from compression to distraction, there may be a problem. This is clinically important because rehabilitation often fails when we focus only on how much load is present. We focus on how much force we are able to produce. Have we produced so much force in the muscle? Is the muscle so strong now it can produce this force? Or the intervention I'm giving, is it making the muscle to contract, to in resistance? But we hardly also pay attention. Sometimes we ignore where that load is directed. Is that load directed in order to bring about compression, or bring about distraction, or bring about motion in a meaningful way? So we need to have some conversations around this. So in knee rehabilitation, for instance, a patient may tolerate compressive loading, better than the same patient will tolerate shear-producing movements. So you need to know, what does this patient tolerate? Is he able to tolerate compressive forces as much as he tolerates shear-producing forces or shear-producing movements? And you can do all of that from the basic clinical assessment. That gives you an insight that when you prescribe movement exercise interventions, you are going to do so in a more meaningful way that we emphasize more of compressive forces and less of the shear producing movements. Have we ever thought in that direction before? That is why and where we have gaps in our assessment and in our prescriptions. And sometimes our prescriptions only focuses on how do we produce the desired force? How do we produce the loading of the musculoskeletal system? But we hardly give attention to the direction that load eventually goes to, that it may compress or it may distract or bring a shear producing effect, which may make some tissues vulnerable and eventually deform them. In shoulder rehabilitation, for instance, the same load magnitude that we exert, remember when I tell you about load, I'm telling you about muscular activity. When we challenge muscles to respond by producing forces, we say that we are loading them. So the same load magnitude may be acceptable in one plane, in the shoulder region, but it may be provocative in another plane, either in the anterior posterior plane, on the transverse plane, and so on. So you need to understand the planes of motion and know whether what works in this plane and it's acceptable is provocative in the other, because it may be shear producing and may deform tissues and cause more injury. In spine care, the trunk position can change. For instance, whether force is transmitted through the structures in a more controlled or a more threatening way. So you can transmit forces through the spine, but you can transmit it in a way that supports the structure. You can transmit it in a way that is controlled by the system, but you may not transmit it in a way that will do all of that if you change alignment, if you change posture, and if you direct the forces from compressive to shear producing, then it becomes more threatening. But everything depends on what is your goal and what assessments have you made and what is manageable, what is tolerable, what is not tolerable. So when we observe poor movement, what do we do? What should we ask? We should not ask only whether the resistance is too high. We must also ask whether the direction of force that is generated and therefore the pattern of tissue stress is appropriate for the person in front of us. I don't know, please can we all mute our microphone so that we don't have these things filtering in? It's not fair. I don't know, MRTV, please can you mute and help us so we don't have distraction. Now, the third point that now becomes important as a result of what we have said so far is to understand the component of these forces. You can see that force now can either be threatening or shear producing. Force also can be compressive, and one force that appears to be compressive and therapeutic in one part of the body can quickly change to become destructive or deformatory in another part. And so, how do you manage it so that you ensure that in every structure, the right in every structure, the right MROTB. I don't know. I think somebody is at MROTB. Can you please respond to me, MROTB? Is it difficult to mute everybody? MROTB?
Good morning, sir.
Onye the number, please unmute yourself. Onye the number, mute yourself.
I think that a host has the right to mute everybody. I don't know why the host is not doing this.
500.
Bashir Sabo, you are the host now. Please, can you mute everybody? Dr. Bashir Sabo.
Yes, sir. Let me try, sir.
All right. I hope you can still hear me. Okay.
Yes, sir.
Okay. Now, that brings us to an important point, because if we understand that forces can play a role that can enhance and produce the desired motion, and also it can play a role that can result to shear producing movement which may deform tissues, then also we need to first of all resolve forces into components in order to improve our clinical interpretation of them and to understand their application in the proper context. Because forces have components, and we can resolve them in the three Cartesian planes. We can resolve forces vertically, we can resolve forces horizontally, we can resolve forces also in the X Cartesian plane. So we can resolve it in all directions. For me, I will always want to make you understand what this means. Vertical component of force means that the force can act upwards, it can also act downwards. Every force you apply have those three components. But which one pulls more? It is the one that pulls more that determines the resultant effect. So a force can act upwards, it can also act downwards. A force can act forward, it can also act backwards. So the vertical component, the x-axis, the vertical component, the y-axis, and then the horizontal component, the x-axis, and then the backward resultant effect of the two, the z Cartesian plane, which I always want to look at as resultant plane. But for the purposes of what we are saying now, it may even be the backward or the summation, the resultant summation of both. Now, let me also take a look at the slides and show you what I mean. If you take a look, our slides are now moving to resolving forces into components, especially vertical and horizontal components. And they connect this to our gait or our movement, to our lifting, landing, and ground reaction force interpretation. What is ground reaction force? Every force that is exerted on any surface according to Newton's third law, it says that action are equal and opposite. So when you walk, you impress your body load, your body weight on a supporting surface. And when you do so, you are already impacting a force. You are impacting an action, a force on the ground, on the supporting surface. The supporting surface also responds to you by impacting a force directly opposite of what you have impacted on it. That is what makes you to buckle and fall down if you are wearing a high heel shoe and you do not balance those forces properly. Because there is an impact from the ground against your own impact on it, you tend to balance these forces so that there is a kind of balance that enables you to move forward. If you do not balance it, the one that is operating against you from the ground may overwhelm the one that your muscles generate to stabilize the knee joint. The knee may wobble, the ankle may wobble under the impact of the ground reaction force, and that will push the base area of support, push the center of gravity outside the narrow base area of support, resulting in disequilibrium, eventually leading to either a fall or a tendency to fall. So there must be a balance in these forces. Action and reaction are equal and opposite, but does the tissue have the capacity, the neuromuscular system will have the capacity to manage the external demands, the force demands of these external forces? Why do we see people who wear high heel shoes fall? I've explained it. When their tissues are not able to generate sufficient forces to manage the demands of these external forces, the force demands, then they collapse. And one of the things that makes it difficult for them to do is because the gastrocnemius, the resting length of the gastrocnemius muscle, is shortened by the high heel. Remember, if you look at the anatomy of the shoe, towards the heel of the foot, the shoe becomes more hilly. And therefore, the foot is not resting on the ground in a level manner. It is slanted. The foot is slanted by the very structure of the shoe itself, because the hilly part, which is behind, is quite high, and then the toe part makes contact with the ground is low. So there is an angulation. And this now stills, like teething, it stills the propulsive power of the calf musculature, which you need to propel you forward. And you also need some of those power to balance the turning effect of these forces around the ankle and stabilize the knee, the proximal knee joint. And in such situation, because the power of the gastrocnemius is now minimized, it is stolen by the shoe, which have shortened its resting length. His ability to contract maximally to meet with the demands of the forces, the external forces of the ground reaction force, makes it difficult sometimes for you to present a fall. And when you are battling with fall, tendency to fall, increased tendency to fall, then your motion moving forward will simply be dragged backwards. So you tend to walk slower than walk optimally. This happens as you age. You see that the way you use the high heel shoe is no longer the way. At some point, you will just resign. The reason is because the external forces acting on you As a result of the impact of your foot on the ground, the external forces, your neuromuscular system now lacks the capacity to deal with them, to manage them. And this is something we need to be thinking about also in patients. But we hardly pay attention to those possibilities. And that is what is demanded by movement science. So movement science gives you an insight that you need to understand how the forces are resolved. The component of these forces, which one is higher than the other. And therefore, you tend to know which direction the forces will be acting. Because it is not just to generate the force, but you must know the direction the forces are acting. So when we tend to understand these components and how they act, then we can connect them to our walking or gait. We can connect them to lifting. We can connect them to landing. We can connect them to ground reaction force interpretation. You know, what we have noted in these slides is that patients in pain, and what we also note in our clinics, patients in pain avoid certain components of the forces. Patients in pain avoid certain components. The vertical, which one are they avoiding? Is it the vertical component? Is it the horizontal component? Is it the Cartesian, the Z component? Which one are they avoiding? So you need to understand the component that the patients are avoiding. Every patient is not the same. But whichever one they are avoiding, the resultant effect is that one they are avoiding determines the type of compensatory strategy that the patient will normally adopt. And usually, when they have pain in their knee or pain in the lower limb, they adopt a strategy that makes them to take shorter steps or reduced push-off. So they don't push up anymore with maximal force because the blowback from the ground reaction force of equal magnitude, they cannot contain it. They can't handle it. And so what they do is that instead of pushing off maximally to impact the ground with maximum force, knowing that they will, if they impact the ground with 1,000 Newton force, they will get 1,000 Newton reaction backwards from the ground, a backlash. And they cannot manage that. Then they now begin to tread softly. They only impact a little bit of those force. And then they take shorter steps because they can't afford to take longer steps, so that they can manage the displacement of the body center of gravity. Therefore, in such situation, shorter steps that they take and the lesser push-off that they make is a compensatory strategy. Therefore, when you see a patient who has pain in the lower limb, walking shortly and taking short steps, and when you see such a person walking slowly and without so much force in the push off, you will understand that this is a strategy. That strategy will begin to diminish when your intervention becomes more effective. So if your intervention is improving those elements that are responsible for the pain, you will see the patient begin to utilize more and explore more the component of the forces that he has been avoiding by developing compensatory strategies to deal with them. Therefore, they may now begin to utilize more propulsion in the horizontal displacement of the body. So the horizontal component, we witness significant enhancement of propulsion. And also, you also see a change in the step length. The step length will change. Therefore, we can critically and rationally biomechanically reason it that enhanced step length and enhanced propulsion force is an indication that the strategy to limit the body movement in order to avoid pain has significantly been whittled down because there is an enhancement, there is an improvement. That way of walking is what we recognize and call antalgic strategy. We will get to that point. I'm only using this as an example to prove the reality to us. And so when you see the antalgic strategy, it tells you that there is a problem, that this person is not utilizing the maximal propulsive force and is avoiding taking longer steps. And these are strategies, they are abnormal, they are compensatory strategy because he is dealing with an underlying pain. And this pain may arise from trauma or from a deformed tissue. Therefore, he is trying to avoid generating or loading the system in a manner that will increase shear movement. So shear producing movements are avoided, movement that will tear apart that structure where the pain is emanating from, either the ligaments or the tendons or the muscles. And so you begin to see this compensatory drive. This is an important bridge from mechanics to functional observation. So you see how the biomechanics have now shifted to function. An analysis that gives you a biomechanical insight and anchors it on functional challenges of the patient, which you need to know and also to know how to deal with it. Yes?
Sorry, I think there are a lot of complaints that the slides are not moving. I mean, maybe it's for some, I don't know. Mine also is not moving. So I don't know whether you are on one slide for long or it's just that it's not moving.
Dayo, are you there?
We're still seeing the one that's saying resolve forces into components, and that has been on for a while now.
Yes. What you see me do.
Oh, that's the right slide, right?
Yes. What you see me do is I'm just discussing force resolution.
Oh, fantastic. Okay.
Yes.
Wonderful.
So I just put up the slide, but I'm just discussing and giving a lot of flesh to that slide.
Oh, all right.
Because the slide is just a talking point for me.
Okay.
So I'm just dealing with that around issues around that. So I'm just trying to give more meaning. So please, sometimes you will observe that these things will happen, but I do it intentionally so that I don't just look at the slide, gloss over it, and move on, but I try to put some flesh to them. Now, a patient actually does not need, so it is important to know that what I have just described and the phenomena I've just tried to bring their minds to, which is a common occurrence we see in the system, is just an important bridge from mechanics to functional observation. So a patient does not really need to understand force decomposition mathematically. When we talk about force decomposition, it means breaking the forces down in a mathematical sense, F1, F2, F3, that acts on the three Cartesian planes. A patient does not really need to understand it actually for us to, use it clinically. So we use it when we recognize that movement is not simply forward movement. So when you talk about movement, generally, when you are dealing with movement science, it doesn't mean translation from point A to point B. No. Movement, there is more to it because it means that there must be a vertical support because the force is resolved vertically. It moves up and down as you go. It means that there must be a braking system because as you move forward, there is also a ground reaction forces moving you backwards. It means there will be a propulsion because, of course, your own gastrocnemius, the calf musculature of your limb, will propel you forward. They generate forces, they load the system, and they propel you forward. So you see that we resolve these forces, the one that propels you forward, the one that breaks your movement forward and pushes you backwards, and the one that also moves up and down in order to bring support to your entire skeletal structure. The ground reaction forces, therefore, can interlock with the body weight if there is stability around the knee and around the joints to support the skeletal structure. But when one is not managed properly, or when one is stronger than the other, that control, there is an imbalance and you may likely fall. So we use it. We use our understanding of these forces, our resolution of these forces. We use it when we see that a patient with a painful knee, for instance, like osteoarthritis, may reduce loading response, or that a hemiparetic patient may reduce forward propulsion on the affected side. Then we use our knowledge of force resolution to determine what force we must give and what force we should not, what component we will emphasize, what component we should not. Should we be emphasizing the propulsion component, or the braking component, or the vertical support component? So whenever you hear movement, movement is not just moving forward. No, every movement comes with a vertical component that supports the structure. Another one propels the body forward, another one breaks the movement and pushes the body backwards. Even as you're moving forward, one force is pushing you backwards. The only reason that you are moving forward is that the one pushing you forward is greater than the one pushing you backwards because of the way you have aligned your body. And when you are prescribing same to a patient, you must understand these components and which one you need for this patient. Should your emphasis be on supporting the patient first before propelling the patient forward? So it means that when you are dealing with a hemiparetic, for instance, where you have weakness of the propulsive muscles, our intervention, especially when we want to move them from lying to standing, the emphasis will not be on the propulsion. Emphasis becomes on the vertical support. But these are loading. We are actually loading the system and priming them up, And then when they start working with their Zimmer frame, what is our intervention? Our intervention begins to shift from vertical support to propulsion with very careful attention to the braking system, the one that pushes them backward. That one also takes a center stage, but it simply we simply harness it in such a manner that there is a controlled leverage to allow the body move forward in a controlled manner, but with the braking system serving as a safety catch. Even the patient itself exerts those control themselves, and they don't need to understand how force are resolved into these components before they apply it themselves. But we try to manage them, use some components in our prescription to enable them maneuver and improve. We want to improve the vertical component. We want to improve the horizontal, the propulsion component. We want to improve the braking component. Which one are you improving? Which one is the problem? Which component is the patient using? Have you thought about that before? When you are doing your assessment of movement in the patient, have you tried to resolve the forces in a clinical, meaningful way? I think that this should give you a food for thought. So for an expert audience like this, the main clinical value here is interpretative, not description. We describe a lot, we don't interpret. So first components help us differentiate between the primary impairment itself and the adaptive strategy that the patient have adopted. So we should be able to look at the force resolution and say this is actually the impairment, the primary impairment that the patient have experienced. But this component is coming from the adaptive strategy. The primary impairment made the patient to use this adaptive strategy. Therefore, once I see this adaptive strategy, I know that the primary impairment may be this. So you have a clinical reasoning logic that tells you that when you see a short step and reduced proportion, the adaptive strategy is antalgic gait. That means that there's a pain arising from a structural deformity, a pain arising from a deformed tissue in the system. And therefore, you have to be careful to avoid other motions that are shear movement producing. Shear producing movements, you avoid them in that instance, and then so that you don't damage the structures more. So you take a look at the compressive forces and see how you can utilize more of them. So and then you drift a little bit into the other ones. So now when you have reduced push-off, that the patient has reduced proportion, he's not digging the toes into the ground properly to push with force. You don't just merely see it as abnormal gait. You don't just merely see it as an abnormal pattern. It may represent deliberate unloading. The patient is unloading. What do you remember? I told you that loading simply means all the activity that we subject the system to in order to generate a force. As we are, engaging in those activities, we are loading the system. So every activity that will result in force generation talks about loading. So, but when we can actually put those activities into motion and generate those force maximally, but we deliberately refuse to do so, even when the circumstances should require us to do so, a patient deliberately does not do so. It means that that patient is deliberately unloading. He refuses to load up. As he's walking, you observe that even when you try to say faster, faster, instead of loading the system more and propelling forward, he's even taking shorter and shorter and shorter steps. It means that this patient is deliberately unloading. What is it that is responsible for that? So when you see reduced push-off, it doesn't just mean that this is an abnormal gait. When you say it's an abnormal gait, what you have done is you have described. You have not interpreted. Interpretation warrants you looking and identifying at the key component of forces acting and why they act, and understanding the adaptive strategy that is consequential as a result of those forces. So you begin to now see that it could be a deliberate unloading or plantar flexor weakness, or fear of fall, or pain, or insufficient motor control when the vertical component is not there that supports the system. If it is insufficient, if the system is insufficient in that direction, you can actually have a fall, and the patient may deliberately unload. So you may begin to see what you observe as reduced push-off. You see, you will see it manifest as reduced push-off. But reduced push-up is a description. What is the thing responsible? That is where the interpretation comes in. So that reduced push-off could be as a result of deliberate unloading. It could be as a result of plantar weakness. It could be as a result of fear of fall, or due to pain, or due to insufficient motor control. Which of them? And by the time you understand and state clearly that you have resolved these components and you have seen that this is because of fear of fall, or this is because of insufficient motor control, where the vertical component is responsible, or plantar flexor weakness, where the horizontal component comes in, or deliberate unloading, which deals with the muscles themselves that should be loaded, refusing to load, then you see you have narrowed it down specific to clinically beneficial or meaningful diagnosis. And not just a mere description, I see an abnormal, gait because I see a reduced push-up. So this is abnormal gait. That abnormal gait is descriptive. Yes, it is helpful, but to a reasonable extent, it's not as meaningful as it should have been if there is interpretative analysis. I bring us to the next topic in a next principle here, and which is critical and fundamental. So we have looked at forces, we have looked at their resolution, we have looked at those dimensions, and now we are looking at the fourth one, the torque. This is critical to us because torque explains why some movement become difficult or why some movement become painful. Now, the conceptual center of this first module in this lecture is moment. You have been hearing moment of forces or torque. I know when you did biomechanics, some of you hated it because of even the name and the spelling. It sounds very abstract and very physics oriented and some of us don't like physics and all these abstract sciences that Newton created for us. But they are in reality very important blessings to physiotherapy practice, to occupational therapy practice, to rehabilitation practice. They are very important knowledge and contribution that we need to dig more into to understand, because the concept of torque is fundamental. Just like I did mention, that first generation is the basic knowledge we must acquire, and that should form how we reason and how we think whenever we are dealing with motion. In such a way, I want to actually let you know that the conceptual center of everything about movement, when you are thinking about forces and generation of motion, the conceptual center of it is moment, is torque, which is defined in this slide as the turning effect of a force. Yes, moment is the turning effect. So every force can produce turning around a joint. The body is made of so many joints. Remember that movement in these joints brings the motion that moves us forward. Either flexion here, extension there, adduction there, abduction there. So all these movements are coupled together in a meaningful way, and the body leverages them and makes them to be organized into a machine. But this machine has components. Some components are in flexion at some point. Some components are in extension at some point. Some components are in adduction at some point. Some components are in abduction at some point. Some components are in different rotatory motions. And there are even very fine ones, roll and slide and glide. Some components are in all of these. But the body now melds every structure from head to toe together with their various expressions of these components of movement. They are melded together. Remember that around each joint, the type of movement will speak to a class of lever. So some levers are inefficient, some levers are efficient, some levers bring mechanical advantage. The body utilizes at each of these joints whatever it considers necessary to advance motion, but it brings all of the totality of these various dimensions of movement in the joints together into one complete machine with a goal, a single movement goal. So I always say it, that the body is one of the most complex machines, and the movement sciences, the basics of it is to understand how the body functions as this machine. and how it brings all these joints together. The movement that occur at them, the turning effect of forces at these joints, how it brings them together, harnesses them together, melds them together into a transient, intermediate, transitionary, low dimensional deterministic machine that will help us achieve the goals of the movement task. Remember, it is because of this reason that the same exercise prescription that you give may not be the same mechanical task that is experienced. So you need to know, you need to have a good understanding of the turning effect of the muscles, the turning effect of forces, and what can make those turning effects to vary. Because if you understand these turning effects, what can make them to vary, then you will now know whether the same exercise program you prescribe for patient A will create the same mechanical task for patient A, or it will create a different mechanical task. And that means if it will create the same mechanical task, you need not prescribe what you prescribe for patient A, even though both of them have osteoarthritis. But we go ahead to just what is required in osteoarthritis? Just fire them, put tell them to do strengthening exercises. How many RMs? Repetitive maximum. Yeah, just do it this way. Do it this way. Use the long boot. Once you get it, it's okay. I used it for my patient yesterday, and I got a good result. No movement scientist will think in that way. Because that exercise prescription you have given to patient A that worked created a different set of tasks for him, which challenged the system in a different way, but for patient B, it will not. So you must personalize your prescription by understanding the forces that act, by understanding the strategies that are there, by utilizing the right component that needs to be targeted in your intervention. Because for somebody in patient A may have had a challenge with vertical support component, but doesn't have problem with a propulsive component, or may have a problem with the braking component, but not with propulsive component. And then you give what you give to patient, all of them have OA. And some of these things may vary because they are their body structure. You see, and the nature of injury they suffered from. So what works for A will not work for B. Therefore, the patient relies on your skills and competency as a movement scientist to isolate what the problem is. That is where clinical reasoning becomes the most portable tool for a movement scientist, for a rehabilitation expert. And some of you may always listen to the registrar talk about clinical reasoning, competency, skills, and so on. You may not understand it, but that is the right way, and that is where the world is going to, and that is what makes a difference. Without clinical reasoning, we only look like technicians. We only behave like technicians. So this clinical reasoning, but for you to reason, you must understand what you're reasoning about. If you lack this knowledge, what can you really reason about? That is the issue, and that is why I always feel encouraged and feel motivated each time MRTB invites me to deliver this kind of lecture, because it gives us opportunity to begin to explore these domains that are dormant and which we hardly pay attention to. And I expect that by end of today's workshop, we should have some information that prepares us for the practical component. So what am I saying in effect? The conceptual center of everything we are doing in this first model is moment or talk. And you have seen the slides I have here. It defines it as the turning effect of a force, and it's measured in Newton meters. Now, the presentation that you are looking at explicitly and clearly states that if force causes translation, then torque causes rotation. Force will cause a translatory motion. Translatory motion is the movement of a body from point A to point B on a straight line. For a human body, in very advanced biomechanics, we look at the body center of gravity as the point through which the resultant gravitational force acts through. So whenever we are talking about movement of a body, we are actually looking at the displacement of body center of gravity. So when we say translational motion of the body, we are almost talking about translation or displacement of the body center of gravity in a straight line from a point A to a point B. Translatory motion always occurs in a straight line because forces act in that way. However, force causes translation, but torque causes rotation. Force causes translation. Torque causes rotation. And we have defined torque as the turning effect of force. And force causes translation, movement in a straight line, displacement from a point A to point B. But as you are being displaced by this force in a straight line, that force also exerts a turning effect around your joints that cause rotation. So as you walk, there is translation and there is rotation. Please do not forget it. So there is force translating you forward. Each turning effect rotates your body parts around certain axes as you walk. So you are dealing with two things: translation and rotation. And so if force causes translation, torque causes rotation. And you must know that joint torque is a major reason movement becomes difficult or becomes painful, especially in the knee and shoulder rehabilitation. You see? So as you walk, force produces translation. The same force now produces torque or turning effect around the joints of the body. And they now creates a problem for movement. So it makes movement difficult. It can make movement painful. Torque creates difficulty for movement forward. It can make it difficult, it can make it painful. And it can happen especially when you are looking at the knee joints, which are key joints for stability, and the shoulder joint in rehabilitation. So this is where biomechanics becomes immediately useful to expert rehabilitation practice, because patients do not experience force in the abstract. They don't experience force as an ideation, as an imagination. They don't experience it as an intellectual conjecture. At the point, at the joint itself, at the joint level, they experience rotational demands as they walk. A patient is rising from a low chair. That patient is not only lifting the body mass up, but the knee extensors must generate sufficient internal moment to counter external flexion moment. So when you ask your patient to rise from a chair, and you are seeing that for him to rise, there must be movement at the knee. Isolating the knee joint particularly, you will see that when this patient is lifting the body mass, which is the body weight, from that chair, knee extensors are required to generate that. So they contract and they become loaded. And they must have sufficient power. They must have sufficient internal moment. Because remember, there must be a turning effect. Knee extensors will bring about knee extension moment. It will move the body into knee extension direction. It's a rotation. It's not a translation. But if it must generate sufficient internal moment, it is required that it does so to counter an external flexion moment, because the force of gravity is pushing the same knee into flexion, whereas the knee extensors are pushing the same knee into extension direction. So there is a rotation, two counter rotations. The force of gravity is acting on the person getting up from the seat at the knee joint to push this person into flexion moment. And the body weight, which is actually what the center of gravity, the force of gravity amplifies and uses as a tool to achieve that moment, drives you further into the seat in a flexion moment. It's an external force. So you need an internal moment of forces by the extensors of the same knee to drive you into flexion moment in order for you to stand. I want you to look at it so that you understand two things happening to the same person who you have given a command. So a patient holding the arm away from the body is not merely using the shoulder. When the patient, you tell him to abduct and adduct, he's not merely using the shoulder. The shoulder musculature is actually resisting a torque that changes the limb posture. It's because as they are moving the arm from the middle towards abduction, the force of gravity is acting, creating a turning effect and pushing the same shoulder, the same upper limb towards the midline, pushing it downwards into adduction. So it's not just, use the shoulder. No, there are a lot of forces acting and they are at play. One has to either balance or overcome. So when you do all that, you need to understand these forces and their turning effects and to resolve them. And it gives you a sense of direction, what you are doing. Remember the formula. The moment is equals to force times perpendicular distance from the fulcrum. So that is, the moment depends on the magnitude of the force and the perpendicular distance from the joint axis. So the moment arm becomes very critical. And that is why the moment arm is the most important consideration in physiotherapy prescription, especially when it involves movement. So the slide describes this as the most important equation for this session because it guides exercise modification, it guides exercise progression. That is absolutely correct. It guides exercise progression, it guides exercise modification, the moment arm. The principle of which I speak, number 5, is the moment arm as it is. The moment arm is the clinician's most practical mechanical lever. And if you do not have an understanding of this, and you make prescriptions of movement for the patient in different exercise situations, then you may be doing, out of ignorance, something that may not help or may be counterproductive. So one of the strongest sections in the slides you are going to see in this session is the treatment of the moment arm. The moment arm, the presentation notes that accompany this, the moment arm is the perpendicular distance to joint axis. And of course, it argues that very small changes in posture can produce large changes in the torque. Just a small modification of your posture can change the torque, can change the turning effect Most importantly, you can see that although clinicians may not always be able to change the force, they can often change the moment arm through posture. Because sometimes we may not be able to influence the force generation because that force, the muscles that we generate it are may be injured, maybe they are denervated, maybe there is, but even though we can't change force generation, we can actually influence, we can actually, change the moment arm by changing the posture that the patient adopts. We can change the resistance placement. We can change the joint angle. We can change the movement, strategy. We can change these things because of our knowledge of force and torque. They are dependent on posture, on structure. They are dependent on location and strategies adopted. We can maximize this to our advantage, or we can not understand them properly and they work against our intervention protocols. This is where clinical biomechanics becomes very powerful, especially in resource limited context. So when equipment options are limited and we can still manipulate mechanics, then we have some advantage. Let me give you a few examples. For instance, when a patient with painful knee osteoarthritis may find sit to stand intolerable from a very low chair, but manageable from a higher chair, what do you think you have done? You see, you have utilized the knowledge of posture and position, knowledge of biomechanics. And you can actually, implement the same program that you need for your patient by simply changing the height of the chair. So when you see that there is a problem or what their internal capacity cannot sustain, you change the position of the body structures by either changing the platform or reducing the platform. Automatically, what you have demonstrated here is a good sound knowledge of progression or regression based on understanding of moment and forces. So the force is similar. The force is similar because you are going to challenge the forces of extension. Extensors, we have to lift the knee into extension position. So for somebody who is sitting on a low chair, the forces are similar. They are all extensor forces acting. For somebody who is on a high chair, they're all the same thing. Forces of extension acting. But the magnitude is not the same. The position is not the same. So by changing the position, you have altered the magnitude of force you need to accomplish the same by changing the height of the chair. So are you seeing how these understandings becomes relevant? So a patient early after anterior cruciate ligament reconstruction may not tolerate distal resistance in knee extension. But once you shift the resistance proximally, it can reduce the torque without, abandoning the quadriceps loading. You can still load the quadriceps, but you have already shifted the torque proximally, you see? And then everything changes. So a patient with shoulder pain may also tolerate work in the lower range before you progress to greater elevation. So you may walk from midline to mid-range, and then you continue to improve the range as time goes on. So you are now utilizing the range of motion, the position, through which the arc of movement to determine how you modify. So because the moment demand changes with the arm position, so because the moment demand changes with arm position, you can utilize that knowledge to give to every individual what is most suited. So the expert rehabilitation message is this: moment arm manipulation is not a compromise. Moment arm manipulation is not a compromise at all. It is a scientifically grounded method of exercise progression and regression, which we can utilize based on biomechanical insight or movement analysis. The sixth aspect that is fundamental to this module 1 is internal and external forces. You need to distinguish them because we have been speaking based on all the illustrations I've been giving about loading of the muscles internally and externally. And so you see that this becomes an issue that you need to distinguish the internal and external forces that act on the human body in terms of biomechanical components that sustain them and what their implications can be in different contexts and in situations. So the slides makes a very important distinction between the external forces, which includes the gravity, the ground reaction forces, the applied resistance that the therapy gives, the environmental loads because of the terrain. When you are climbing a mountain, when you are walking through a slippery area, they all create environmental loads, different environmental loads. The environmental load that is exerted, that challenges and perturbates the muscle to respond to when you are climbing a mountain or a hilly area is different from when you are walking on a flat surface or when you are walking on a slippery surface. There is a different environmental load in such situations. And then we have the internal forces, which comes from the muscle tension, from the tendon forces, from the ligament stress, from the joint, contact forces, and so on. This speaks to internal and external, and that is something that we need to understand. But there is always a caution, because when you understand the internal and the external forces that act on the body, they caution that clinicians often underestimate the internal forces. Sometimes we, know that even a small external weight can create large internal joint forces because of the liver system. The liver system can amplify. So just a small external weight may cause or create very large internal joint forces because of the liver system that comes into being, that is actually elicited, and the stabilization demands that is required. So these distinctions should actually shape how we prescribe and how we explain exercise. So, for instance, an exercise may look light externally, but may be mechanically demanding internally. This is particularly relevant when you are dealing with conditions like tendinopathy, like patellofemoral pain, when you are looking at rotator cuff pathology, when you are looking at post-operative loading progression. Very small external weights can create very huge internal load demands, and you need to understand this. So it also matters in patient education. So when patients say things like, but it is only a small weight that I carried, it's only a small bottle of water, it's only a small, dumbbell, we must sometimes explain that the internal joint and muscle demand may be much, much greater than the external load suggests. So, because we know that the liver system is capable of amplifying that external small object, the demands that it exerts on the system, the loading demands, because of the nature of the liver system. If you look at the first class liver, second class liver, third class liver, and the mechanical advantage or disadvantage. So the same load, if you apply the same load in the first class liver system, it may give you something that is different. And then in a second-class liver system, and third-class liver, it may give you something intolerable because of the demands. So for Nigeria's rehabilitation setting, I always believe that this is also relevant when we improvise with functional tasks rather than when we use machines. So body weight tasks may appear simple, yet they can generate substantial internal load. And this is something sometimes we don't seem to realize. Therefore, when we exercise, when we select exercises, we must judge. We must judge by mechanics, not by appearance. And that now takes us to the liver system. At the end of this module 1, we take some time off before we return to module 2. And we are almost coming close to that, but we still have some miles to go. Now, liver system explains why muscle works so hard. Okay? Because we have been hearing that in physics. If you look at the slides I uploaded, you see that it describes the human body as a liver system, as a system of livers in which the bone normally acts as the liver, the joint as the fulcrum, the muscle as the effort force, and then the load as the resistance. And we are all used to that. So the bone is always, the liver itself, and the joint, the fulcrum, and then the force. In actually, the muscle as the effort force, or that is applicable in that liver arm, and then the load as the resistance. So if we look at it, we now take a look at the first, second, and third class livers and their implication, because they have implication when we highlight them, especially most human movements, because most human movement are third class livers. Third class livers in the sense that they promise speed, they prioritize speed, they focus on speed, they focus on range over force efficiency. You see? So the clinical implication when you focus more and prioritize speed and range over force is that the muscle must produce high forces, and the patient with weakness or pain may struggle a lot unless the mechanism is modified. So the most part of the human body fall within the third class liver, where the focus is on generating forces, where you prioritize speed, where you prioritize range, where you prioritize speed and prioritize range over the forces. And therefore, for you to now generate the forces you need, to generate the speed you desire or the range you need to cover, the clinical implication is that the muscles must produce very high forces in order to accomplish that speed or accomplish, that range, as the case may be. So most of the things that we do as humans, a lot of forces are generated. And for every force you generate, there is a metabolic cost. There is an energy cost. The ATPs are expended. So more ATPs are expended. Tendency to create fatigue is higher in the body system or in liver system, in mechanical liver system, where third class livers are prioritized, or where most of the liver system are third class livers that prioritizes the speed and prioritizes the range than the forces. And so more forces are required to move through a small range, and more forces are required to move through the different layers of speed. So this is a crucial point because human movement is not designed for mechanical economy. Because of this, human movement is designed to consume so much energy because the most part of the body is third class liver. So you don't expect to see that there will be a movement will have so much energy economy in a way that you see in crowbar. It is designed for versatility speed. It is designed for versatility range. It is designed in that way. So there is versatility, there is speed, there is range. So much range in the human body. And that is why even ordinary movement can be very demanding for patients that have some impairment. So when a patient that is weak falls at a simple lift or fails to do a simple lift or a simple transfer in the eyes of you as a therapist, the problem is not always lack of motivation or poor cooperation of the patient. No, the problem is the liver system itself. It may place them at a very serious major mechanical disadvantage. And that is something you, as a clinician and an expert, need to understand and need to hear. That when you see patients fail in those lifts, in those shifts, in those, exercises you are giving them, either to lift something simple or do some transfers, they don't do so because they don't want to cooperate with you, or they don't do so because they lack motivation. They fail because of mechanical disadvantage. So an expert should think about it, because this has implication across neurological rehabilitation and the orthopedics, geriatric rehabilitation, and sports medicine as a whole, because it reminds us that when tissue capacity is reduced, we should not insist on the same level of challenge or on the same liver challenge. Whenever we have a reduced capacity, which is brought about by impairment, we should not insist on the same liver challenge. So when your patient has impairment, you should be thinking of modifying the liver system in the body. Because remember, most of the body is third-class liver system. Third-class liver system have mechanical disadvantage. A lot of small change in loading will cause so much forces to act. It emphasizes speed, versatility, and range of motion. However, it does so at the expense of forces. So it has this mechanical disadvantage naturally and inherently. Therefore, whenever you have a challenge of impaired tissues, where the tissue capacity is reduced now, the muscles are affected, you should not insist on exercising the patient using the same liver, natural liver. You need to modify that liver because the forces are too much. And they may not have a requisite energy resources to execute them over the period you are expecting. We should adjust the system. We can adjust it through support. We can adjust it through alignment. We can adjust it through the range of motion. We can adjust it through the liver length. Instead of full arm length, you can exercise at short arm length. Or task modification. By all means, look at the liver system. Move it from a mechanical disadvantaged liver, third-class liver. Move it upwards. Shift it. Maybe to second, maybe to first. But you must modify the liver system. You should be thinking of how do I modify the liver system once you see that the tissue capacity has been impaired. And that brings me to another topical issue, which whenever we are modifying the forces and what they do, we are thinking about power, we are thinking about work. Work and power are not the same. Of course, we already know that. And function often depends on power. Most of our function in life depend more on power than on work. Activities of daily living depends more on power than on work. So the slides you have simply define work as force over displacement, then it defines power as work done over time. What are they saying? They are emphasizing that many patients can generate force slowly, but cannot generate power quickly. Because if you look at it in that sense, you will see that work speaks to displacement, force over time, force over displacement, and power speaks to work done over time. So power is work done over time, whereas work is expressed as force over displacement. So work is force over displacement, and power is work done over time. They emphasize the fact that many patients can generate force slowly, but cannot generate power quickly. And they link this to difficulty with things like stair climbing, like rising from a chair, like fall prevention, and so on. The sit to stand example I gave earlier is especially very clear. So when you are asking an older adult to rise quickly because you are doing a TUG, time up and go test, and he needs to complete it as quickly as possible within the 12.3, 12.8 seconds range, you are asking an older adult to rise quickly. You are actually testing power more than you are, than the strength. You are testing power. And most of activities of daily living and most of the things we do, most of our function test this power, which is work done over time, and not really force over displacement. So these distinctions matter greatly in rehabilitation because too often we assess strength and assume that function will follow. So that when strength improves, function will improve. That is not true. Strength can improve, function will not. That is mechanically sound, and that is biomechanically sound. And that is one thing you need to know. You need to be thinking in that range because many functional tests in daily life are time sensitive. So recovery from a trip, rapid step initiation, stair ascent, or maybe protective movement during loss of balance, all of them depend on timely force generation. You see, so whenever you are looking at events in life, you see that many functional tasks in daily life, they are time sensitive. So you tend to look at power more, work done over time, than force displacement. Okay, so you tend to look at it in that sense. So if you look at things like recovery from a trip, you have done a trip, you need to recover from wear and tear, or you look at rapid step initiation, you look at step ascent or protective movement that you make during loss of balance. All of them depend on timely force production. But in Nigeria, where aging population is growing now, stroke is coming in, osteoarthritis is coming in, the condition is now more, and even more in women than in men. Physical inactivity is part of it. All these are increasingly common in rehabilitation practice. The work power distinction should therefore influence our prescription. Are we going to understand whether we are laying emphasis on work or laying emphasis on power? The functions that we do more are time sensitive. Therefore, the emphasis is more on power and less on force. So patients may need not only force generation capacity, but they also need to have safely graded power development. Once, healing stage and motor control permits it, you need to emphasize safely graded power development. How this work is done over time, rather than force generation. But most of our rehabilitation focuses on power and force generation, force generation, force generation. Resistant exercise is to generate force, but not power graded development. This takes us now to the workshop problem, because the workshop problems translate mechanics into rehabilitation reasoning. That is everything that this workshop problem is all about. This workshop intends to solve a problem, intends to, make us understand how we can transit from understanding biomechanics as an ideation Rather, how we can harness biomechanics into rehabilitation reasoning. So the workshop portion of this slide is one of the strongest teaching features that you will have, because you will have some kind of workshop take home that you need to take a look at, and possibly you're going to present that on Monday. I'm going to, give you some kind of workshop presentation, a small 5 minutes presentation that will make you think a little bit more and make presentations to us on how you translate mechanics into rehabilitation reasoning. So I will be asking you to identify force, identify moment arm, compute moment, interpret its meaning, suggest the clinical modifications that need to be made on the basis of that. The C to stand example, for example, you calculate a new moment of 17.5 Newton meters from 350 Newton and 0.5 meter moment arm. When the moment arm increases to 0.0 meter, the torque itself rises to 28 nanometer, despite no change in force. These are some of the things that I want you to look at and reason through why it is so. So there will be some kind of exercises that you need to, do, and you begin to think in that sense. In this situation, for instance, where a separate knee example also shows how torque can be produced or reduced by moving resistance closer, or reducing range, or slowing speed, or changing the position of the lever arm. So this is the exact style of reasoning that I want to promote, that this workshop is intended to promote. We need to understand why and on what occasions they should be applied based on our calculation. So we as experts need to, have this reasoning model, and we should be able to teach, not merely calculating a value, but linking this value to compensation, then using biomechanics to modify task difficulty, so that in every situation you see yourself, you can raise hypothetical questions in that situation and utilize your clinical reasoning to see how you can modify the task difficulty in order to deal with the challenges that is presented in that instance. So there will be some little calculations for you to do and then to interpret it in that sense. I will want to finally look at the clinical relevance of rehabilitation in Nigeria, and that is something you need to capture also in this the workshop, little exercises I will give you, because based on what we have seen so far, biomechanics gives us a common language for making rehabilitation decisions. We can make that rehabilitation decisions across disciplines, across settings, rural setting, urban setting, in physiotherapy, occupational therapy, orthotics and prosthetics. If we have experts in rehabilitation in Nigeria, then the most valuable synthesis is that we are able to translate and to have clinical relevance of biomechanics for rehabilitation. And once we have the right language, have a common understanding, it will cut across disciplines. We will speak the same language. It enables us to speak the same language no matter our resource level, whether we are in poor resource area or in a high resource area. The same language of biomechanics and reasoning is applicable. No matter the tools you have used, it is the same language. Whether we are managing stroke at a tertiary hospital or at a primary health center or at a tertiary, or osteoarthritis in outpatient care, whether we are managing cerebral palsy in pediatrics or sports injury in elite athletes or even in amateur athletes, or musculoskeletal pain in community practice, the same mechanical logic is applicable across. So this module 1 has 4 immediate Nigerian practice implications that I want you to remember. The first implication.
Okay.
The first implication, MIOTB, can you please help me to mute everybody?
I have done that. I have done that. Sorry for the interruption.
I hope you can hear me now.
Yes, Prof.
Oh, all right. So the implication for what we have in Module 1 for rehabilitation practice in Nigeria is, first, it improves exercise dosing. So we know how we give movement exercises, how we prescribe them in doses rather than prescribing exercises by tradition. We prescribe them in the appropriate dose, taking into consideration that we justify them by force. We justify the force magnitude, we justify the moment arm, we justify the velocity, we justify the range. So it's no longer when we prescribe exercise, we do so by tradition. So once we look at the FITT principle, we now begin to fire. But when we bring a tinge of biomechanics into it, we now begin to look at the force magnitude that is required. And we look at the moment arm that is at play. We look at the velocity. We look at the range. This brings in some kind of improvements in our dosing, because our dosing will not just be without range, will not just be without velocity, will not just be without moment and without force magnitude targets. The second part is that it will help us to improve movement analysis, because we can now interpret compensation more intelligently instead of labeling them generally as poor form of movement or bad compensation and so on. We begin to label them by giving interpretation. What type of strategy is this? What type of compensation is this? And what component of forces are responsible for them? So we are more intelligent and more intentional and beneficial in trying to design intervention that speak to those strategies, and then that either harness or begin to, degrade those emphasis on those components of forces that are not helpful. And thirdly, it improves our patient's safety, because once we understand torque and internal force, it helps us avoid overloading, and then overloading the healing tissues and making the healing tissues to recover, because we have taken those into perspective. Whenever movement is involved, there is a translation motion forward, and there is a rotational motion around the joints, and so that becomes difficult and that can be problematic. It means that we have to look at how do we reduce that rotational movement, and that means we need to speak at the arm, the liver arm, and the kind of internal forces that are required, so that these things can be ameliorated in a more scientific way and basis. And fourth, this understanding of biomechanics and its application in Nigeria will improve teaching and professional consistency for us as practitioners, because either in multiple disciplinary teams, biomechanics provide shared reasoning across physiotherapists, across exercise specialists, and rehabilitation scientists. It says the same thing. It says the same story. And so this is what is important that we capture in all of it. I would simply say that this model 1 is not simply an introduction to biomechanics. It's actually an introduction to mechanically rational rehabilitation that translates biomechanics into meaningful clinical and portable tool. if you have seen the slides and the sections that we have shared, all that they state is that mechanism allows exercise progression. Mechanism allows regression of exercises scientifically, and that rehabilitation should be mechanically rational. That, if you look at it that way, that captures the entire spirit of this ongoing session. So our goal as rehabilitation expert is not merely to help patients to move. It is to understand why movement is difficult for this patient and what mechanical burden is driving that difficulty. What compensation are emerging as a result of that difficulty, and how we can modify the task so that adaptation becomes possible for the patients without unnecessarily bringing about tissue stress, which can lead to tissue damage. So I looked at this foundation, this first module, as a way of giving us the foundation for seeing rehabilitation, not as a list of exercises, a list of movements that are biomechanically explained and oriented, but as deliberate management of forces in service of function. So if we understand that biomechanics is nothing in the sense that we should be reasoning about it, it's not just an opportunity that provides us a list of movement exercises, but as a deliberate management of forces in service of function, then every other thing can be built upon it. Thank you so much. I will think if there are questions on this, I can take a look at them with you jointly, or otherwise I'll give you 10 minutes break, then we come back to the second module. Okay. If you still have questions, you can put them down in chat rooms, then we deal with them. So we can take 10 minutes, and by 12:26, we switch to the second module. All right. I hope we are here now because we have to start the second module. In the second module, we shall be looking at time-dependent tissue behavior in rehabilitation. If you have taken a look at everything we have said, we have looked at work, we have looked at power, and we have seen that one has to do with force displacement and force over displacement, and then power, essentially work done over time. And most of our functions are therefore time sensitive. And this is something we carry over into rehabilitation considerations, ideations, and rehabilitation reasoning. And it's important for us to look at time-dependent tissue behavior because we have identified that most of our function are in that area where they are time sensitive and they are power-driven strategies and power-driven considerations. Essentially, we therefore need to understand the behavior of tissues over time. We have discussed on the mechanical logic of force. We have discussed on the mechanical logic of torque, the turning effect of these forces. We have reasoned about the moment arm and the lever systems that are associated with it, and we have come to a conclusion that most of the things we do, most of our activities of daily living and the body systems and all the movement around it are structured around the third class lever with major disadvantage because the consideration, major mechanical disadvantage, because the consideration of the system prioritizes force, speed and the range of motion versatility over the forces. And so we do not pay a lot of attention to the forces that are required, either internally or externally. But we have gone ahead to look at how forces over displacement has implication and what it means. And when we speak of power and when we speak of work, and then when we say that work is force, displacement, force over displacement, and power speaks to work that is done over time. And so, having this understanding, we established already that rehabilitation is fundamentally about managing load. As far as biomechanics and movement sciences is concerned, we are managing load whenever we are dealing with rehabilitation. Because remember, we're looking at the external forces that are applicable to a system. And these forces bring about loading. So there are loading demands that are exerted on a system. But the system itself have internal capacity to manage these forces, this loading, these, that are around it. Does the system have that capacity to do so? It's only when the system have the capacity to meet with the external loading demands that that system becomes functional. But when it doesn't have that capacity, that system is not functional. And we have therefore established that rehabilitation is fundamentally about managing a load. In this module, we move one level deeper by asking a more clinically oriented and difficult question. How do tissues, how do they behave when load is applied? Not only in magnitude, but over time. So we are not just looking at loading in terms of magnitude. We are not just looking at loading in terms of direction. We are looking at loading also over time. How do tissues behave? So the slides you see, in it, we have just tried to frame this module around the idea that a tissue in its sense may tolerate load initially, yet still fail after repetitions. A tissue may have this tolerance for a specific load you have given it the first time. It may tolerate it the second time, may tolerate it the third time, but the fifth time, the same load it will fail. And this is the principle behind repetitive maximum. So, and we say this repetitive maximum, once you are able to use this same load, apply it without deterioration in quality of motion, especially flexion extension, over 10 repetitions, then we know that the muscle is appropriately loaded. Because that movement, even though we have exerted external loading to the system, external loading demands, the system is able, has internal capacity to meet up with the loading demands. The neuromuscular system integrity is sufficient to meet up with the loading demand under 10 repetition maximum. So when you talk about 1 repetition maximum, it means that you can load it once and then the system can tolerate. And 10 repetition means you can load it 10 times, you will still have the system behave the same way. But beyond that 10th one, the system may not behave the same way. It may begin to change. That tells us that the behavior of the tissue, changes. The tissue tends to behave differently. When you apply load, not only in magnitude, but over time. So when you see that tissues tolerate load initially, or tolerate it 10 times, it doesn't mean they will tolerate it forever. They may fail after repetitions. And that is why viscoelasticity and fatigue are clinically important concepts that every clinician and every biomechanist must know. Every movement scientist must know. Every rehabilitation expert must know. And we must be thinking in that way. What is the viscoelasticity of the tissues? What is the fatigue level expected and projected in the context of the impairment we are managing? So this statement is central to rehabilitation practices as a whole, because many of the patients we manage today do not break down because of one dramatic load that we have given them. Rather, they deteriorate because of repeated exposure and poorly timed recovery after they have been loaded. Because when you load a system, you must be able to give the system time to recover. Because once you load, it has implication, especially in an impaired system. The desire of loading is to produce motion. But when you load in a different manner, remember that loading can bring about motion or deformity or deformation. So which one is the emphasis? And I am telling you that when we load repeatedly and when we also do not give adequate time for recovery, or when we give excessive duration for recovery, or when we give excessive or inappropriate loading rate, there may be some challenges. We may not be able to have an optimal response. In other words, tissue failure can occur in all of these dimensions, and it's often a time-dependent event. So this is very relevant in rehabilitation in Nigeria, where our patients commonly present late to clinic with different conditions that they suffer from. And that makes it a problem for us because If you continue demanding occupational tasks during recovery, then there is a problem. You know, when a system is already in a challenge and the patients don't come to clinic, they continue to place occupational tasks on this system, then what we are left with when they come is a system that has been more damaged. So you see, when patients also self-manage pain, it tells you that the sheer forces, the sheer producing forces may have been exaggerated by the delay in presentation, and the likely damage to tissues may also have increased. So self-managed pain with incomplete rest among patients may become a pattern associated with the biomechanical derangements that we see in patients who present to clinic very late, or even resume function before tissue tolerance has been restored. We see that in patients who present to clinic very late. So any of these scenarios are common. But in such settings, we need to understand time-dependent tissue behavior, which is essential for safe and realistic rehabilitation planning. And so, if we see our patients presenting late, we already should make up our mind that any of these things I have mentioned is already ongoing. Because where the patients commonly present late, they continue demanding occupational tasks during recovery, or there is self-managed pain with incomplete rest, or they resume function before tissue tolerance has been restored. None of this is desirable. And time-dependent tissue behavior gives us insight what may have happened in such situation, and also gives us insight on what is essential for safe and realistic rehabilitation planning in any of the context. So we just wanted to do this module in order to examine mechanical behavior of biological tissues under time-dependent loading, and then to translate this principle into rehabilitation decision-making. And the slides there that you're going to be seeing, we identify the key concepts. And the key concepts for us is viscoelasticity. And we've been hearing this in physics. We've been hearing this in biomechanics, but we are going to see the clinical application and implication today. And we look at creep, we look at stress relaxation, we look at hysteresis, we look at loading rate, we look at tissue fatigue. These are important concepts in this area. And they connect themselves, they connect all of these directly to load dosing, to flexibility work, to tendon rehabilitation, to return to play, or return to duty, progression, as the case may be. So our purpose in this module is not only to define these terms. We're not here to define what hysteresis mean, or viscoelasticity, or creep, or stress relaxation, what they mean, or loading rate, or tissue fatigue. That's not what we are here to discuss or to define. We are here to discuss them, but not to define them just as mere terms, but to show how they improve clinical judgment if we understand their relevance and application. Let us start by saying that tissues are not purely elastic structures. And I think we all know that. If you understand the rheological model of a tissue, its internal capacity, its capacitance, its resistance, and so on. And most of us may have done that because tissue behaves like an electrical wired system. The first major idea in this module is viscoelasticity. Now, from our slides, you will see that we define viscoelasticity as the property by which biological tissues behave partly like a spring and partly like a fluid. So every biological tissue behaves partly like a spring a spring you use in boosting the shock absorption system of your car. It springs anything that is put on top of it. So tissue behaves partly like a spring. And so when there is a load exerted on a tissue, it springs it a bit, it buoys it. It has a process of generating its own internal forces to spring it. It behaves also like a fluid partly, and that means that their response depends on time and the loading rate, because these are synonymous with the behavior of a spring and the behavior of a fluid. They vary based on time and the loading rate. It also identifies tendons, identify ligaments, identify muscles, fascia, cartilage. We identify these as tissues that demonstrate viscoelastic behavior. So your fascia, the fascia, muscle fascia from your anatomy, tensor fascia lata, and all those fascias that we see in the body, they have this behavior, this pattern of behavior. They are viscoelastic. The tendons, the ligament, the muscles, the fascia, the cartilages, they are viscoelastic. They have that property. But are they of the same quotient? Are they of the same magnitude? Are they of the same dimension and behavior? This is critical and very crucial. It's a very crucial, an important angle to look at it. So that we are not overly simplistic in our thinking and thinking that, these tissues do not have viscoelastic properties and these tissues are just tissues that respond to other biological principles, but have nothing to do with this. No, they behave in a similar manner, like fluid, like spring. So if tissue behave like a purely elastic material, then its response to loading will be immediate, will be predictable, and then it will be independent of how long or how quickly the load was applied. For instance, if you look at the spring of your car, and which behaves purely as an elastic material, or if you look at an elastic rubber, you see how they respond. If they are purely elastic in the true sense of it, then they will be immediately predictable. A lot of things will be predictable. We can look at the loading response and predict it immediately. We can look at, we can have an independent view of how long and how quickly the load was applied. But the human tissue does not behave like a purely elastic material. The tissue deforms over time. And that is why I keep telling you that when you exert certain forces and load the system, you either achieve motion or you achieve deformation. The tissue is able to deform because it is not purely an elastic tissue. The tissue itself can have the properties of a spring and the properties of a fluid. And that makes it not to be a purely elastic material. It can deform over time. It adapts gradually. It dissipates energy. It responds differently under fast compared to very low loads. If you put very slow loads and very fast loading, the tissue adapts differently to all of that. So clinically, what does it mean? It means that the same movement can have different consequences in the patient's body, depending on whether that movement is sustained. Because remember, I told you that loading consists of all the activities or all the movement activities that occur when a system responds by generating a force to meet up with external demand, external load, force demands. Because the moment you have, I put on your head a bottle of Coke, your system responds to that, to sustain it, to carry it. Muscles have to contract, nerves have to work. A lot of things are initiated in order to sustain that. Please, can somebody mute this person who is me? I don't know. Please let us all mute ourselves because this thing is distracting. I don't like it. Mm. I don't think MROTB people are here with me because the people make noise and you don't mute them, and then I struggle to coordinate and concentrate. It makes my job very difficult.
Ransom Udi. Ransom.
Now, clinically, it means that the same movement that we give may have different consequences in the patient's body, depending on whether we sustain this movement or whether we repeat this movement, or whether this movement is executed rapidly or executed slowly. So either we control it, or we do it rapidly, or we do it repeatedly, or we do it for a longer sustained period. There are consequences it has on the tissue. So a slow sustained stretch, which we normally give to our patients, or a repeated hop we ask them to make from one limb to the other, or a sudden deceleration or reduction in speed may involve similar body regions, the lower limb, for instance, but they are not mechanically equivalent. We may put the lower limb in a sudden deceleration while walking. We may hop with our lower limb from one spot to the other. We may have a stretch of the lower limb, sustained stretch of the lower limb. These three activities are not mechanically equivalent because they have different tissue experiences that they create. The tissue experience a different experience when it is stretched or when you hop from one limb to the other. It has a different mechanical experience when you decelerate. You are walking, all of a sudden you want to come to a sudden halt to decelerate your speed. The tissues experience different mechanical experiences. And because of this, we know that these experiences have time dimension, and these time dimension differ across these various biomechanical events. Therefore, these events are not biomechanically equivalent, even though they happen to the same tissue, the lower limb tissues. So, for expert rehabilitation practice, this means we should stop describing load only in terms of heavy or light. I gave him a light load to carry. I gave him a heavy load to carry. That is not how we should be describing loading. Or the system is heavily loaded because the expectations are high based on the type of forces acting in the system that will trigger and challenge the internal neuromuscular integrity and capacity to respond adequately to sustain it. So we begin to talk about heavy and light loading. We shouldn't be talking in those terms, really. We must also think in terms of how long, not how heavy the loading is, not how light the loading is, but how long is that loading done? How often is the system loaded? And how fast is the system loaded? So how long, how often, and how fast? Those are things that have implication for the tissue viscoelastic property, which are time dependent. Because all of these questions that we ask have time components to it. How long do you do this? How often do you do this? How fast do you do this? They all have time components when we answer those questions. Therefore, it expresses the fact that the tissue behavior is time dependent. Let's look at one aspect of this behavior, which we call creep. Creep simply explains why deformation can increase under a constant load. So that when we put the same load on a tissue, when we load a given tissue, or when we load a given structure, and we do so over a sustained period, even though it is the same load, 3 kg or maybe the same kg, 3 the same load, 3 kg of forces, or 300 Newton force. The presentation that you have in this slide defines creep in such, as we know it, as the process by which deformation increases over time, over a constant load. So creep speaks to the process whereby the tissue, the viscoelastic property of the tissue itself deform, and this deformation increases over time under a constant load. So even when the tissue is carrying constant load, it will deform over time. And we must expect that to be. So we don't say, I gave this patient 3 kg, which he can tolerate. I don't know why after 1 hour, the patient is behaving in a manner that is not acceptable. He can no longer carry it again. He cannot carry it because of the effect of creep. Creep speaks to deformation. When the same load is sustained over a long time, then that tissue that sustains it over a long time will begin to deform, and therefore will not have the same integrity and property that will sustain that external loading for too long. The example given is, for instance, prolonged hamstring stretching, where the range of motion gradually increases while the stretch is maintained. If you look at the slides and then take a look at some of the notes thereof, the clinical implication of what we see simply shows that creep may improve flexibility, but may temporarily reduce stability. So joint stability should be considered before prolonged stretching is administered. So because when you give creep, when you give loading, the same load over a long time, you may achieve stretching. You may increase the range of motion of the limb, and that may be what you want to achieve. But what you do not want to achieve has also occurred because of the impact of creep. The creep will naturally deform that tissue over time. And because of that experience of creep, there will be instability at the joints, even though you have achieved increased increased range of motion at that joint. You must therefore give thoughts to stability. When you put loading, when you exert loading, when you demand that the muscles are loaded, no matter by what dimension of load, so long as continuously it is sustained over time, the creep factor will set in. This is very important concept because it now helps us to explain several common rehabilitation observations that we do encounter. We see in situations where patients hold a stretch and gradually moves further. That is not simple muscle loosening. No, it's a stretch your knee joint, and then he stretches it within a given range of motion. And you now say, okay, increase the range of motion, stretch it further. So you now say, the muscles are loosening up, they are loosening up. You see, it is not like that. When a patient holds a stretch for that way and gradually moves further, That is not simply muscle loosening in a vague sense of it. It reflects a time-dependent deformation within the tissue system. So you must understand what is happening when the muscles are apparently in quote loosening up during stretch. What you are experiencing there is a time-dependent deformation of the tissue within that system. So likewise, when postural tissues are exposed to prolonged low-level loading, or when you have gradual deformation, which will occur in such situations, you know, they are bound to be there because you have sustained the same load over a long time, even without a change in the force magnitude that you have applied. But because you have sustained it over a long time, there is bound to be a tissue deformation. For an expert audience like this audience, the critical message that you should have is that creep is not automatically beneficial. Because even though you have loosened the muscles, it creates the problem of instability because the integrity of the biological structures have been affected. There is some deformity of the tissues. It can be useful when flexibility gain is the target that you want to achieve. But you must understand that it may have undesirable effect when joint stability is considered, or when you look at passive restraint, or when tissue protection is the priority. So whenever you are doing any intervention or recommending any intervention that have biomechanical consequences, you must think deeply. For example, prolonged stretching immediately before high demand stabilization task may not always be appropriate, especially in hypermobile or poorly controlled patients. So when you have poorly controlled patients who cannot control deceleration, for instance, when they are moving, to control the limb and they decelerate it becomes challenging. In such patients, why are you going to stretch them? Why must you stretch them before you now subject them to high mobility? So, yes, stretching may be performed before you play football. Fantastic. I gave him some stretching. I gave her some stretching. You can see these athletes, their coaches will give them stretching and after stretching and all those kind of passive exercises. They are toned up now to fire. Fantastic. But what is the capacity of the tissue? Because stretching loosens the muscles, but that losing in quote is actually muscle deformation. There is a creep that comes in. There's muscle deformation that comes in. And the issue is that anytime that you are going to place a high demand stabilization task on any joint, please do not stretch it before that high stabilization demand task is sustained or is implemented. Because if you do so, you will not be able to accomplish that task without injuring the tissues. Because by stretching, you have loosened and caused instability. You have deformed. You have moved that part into a creep. Okay? There is a biomechanical creep occurring. And that means a deformation of that tissue. Therefore, as a clinician, you cannot, because you stretch an athlete, stretch a patient before you place a high stabilization task on that patient. You want the patient to stand on a wobble board, which will place a high stabilization task on the patient. And then you stretch the patient and then ask the patient to stand on a wobble board. Oh my goodness. Already you have deformed the tissue. You have put some creep in there. And believe you me, the results will not be what you expect. And so sometimes we cause the problem because we do not understand these tissues and their behavior, and therefore can't apply clinical reasoning in the context of this management. We are not able to bring biomechanics into our clinical management, and we have the wrong results. So in such situation, you do not stretch. The body does not have capacity for that. And when you stretch, you further deform the tissue. And therefore, ability to wobble when high stabilization demands are placed on it and collapse, even cause more damage, becomes higher. In practical Nigerian rehabilitation scenario and setting, where patients themselves may independently repeat unsupervised stretches for long duration, this concept becomes important for education. You need to educate based on this concept your patients, especially if you have to ask them to do unsupervised stretching. They must know that when you give them home programs to do, stand on the wobble board, do some stretching, they must understand that they dare not under any circumstances do stretching before they switch to the wobble board program. Because there's going to be a problem. Except if the next task the patient will perform does not require high stabilization demands, then you can do stretching, if that is the target and priority. But if you must, thereafter and subsequently, do high stabilization tax demands, you will never do stretching in a compromised neuromuscular system. Biomechanically, it is a way of allowing the creep to take hold, and most importantly, to damage that same tissue beyond what you met it when you subject it to stabilization tax demand. That task will fail. That task execution will definitely fail. And that brings us to stress relaxation. Stress relaxation explains why a stretch feels easier over time. If you look at the slides, it defines stress relaxation as the reduction in stretch over time. So when a tissue is held at a constant deformation, there is a reduction in stress over time. They explain this simply by saying that this is why a stretch feels easier the longer it is held. Because the longer it is held, the longer it is continuously held, it results to a stress relaxation. So the slide deck you are looking at also links this to graded stretching, progressive mobilization strategies, and then controlled load application for safe, range of motion gains. That's okay. This concept has immediate clinical value, when you look at stress relaxation, which speaks to more relaxation under stress, if the stress is sustained over time. Yes, like I said, depending on the next task that comes after and the priority of the pathology that you are dealing with, that tells you what you do. If, for instance, you need to achieve relaxation, you can achieve that if you do prolonged stretching. In that situation, you attain a point of stretch relaxation. But if the system will undergo a stabilization task thereafter that is high demanding, then it will be a wrong approach. But if you are dealing with a system that has suffered from restriction or even spastic limitation or even adhesions and contractures, then you may have to prioritize stress relaxation, where you stretch and maintain the same load over some period of time, and it begins to go into stress relaxation and improve the range of motion as a consequence of that. The concept has immediate clinical value because many rehabilitation techniques involve holding a joint or tissue at a given position and then allowing resistance to decline over time, because there is a resistance that the body holds or that the body, fights back with when you begin to stretch it. But when you sustain it over time, it now allows for that relaxation to come in and that resistance that the body presents to die off gradually. So stress relaxation helps explain why this approach can be effective without requiring maybe repeated force escalation on the part of the patient. However, the deeper clinical relevance is that it really reminds us that tissue response in that situation and context is dynamic. Tissue response is dynamic. Even when movement is absent, the tissue response is always dynamic. In rehabilitation, patients can appear static while the tissue behavior is still evolving. This is particularly relevant, in contracture management or in joint mobilization or in soft tissue work or in prolonged positioning. The expert level lesson that you need to take from here is that tissue tolerance and tissue response are not identical. They are different things. The tissue response and then the tissue tolerance speaks to two different things. A patient may tolerate a position, may tolerate a particular force loading pattern because tissue stress is decreasing. But that does not mean that the tissue has become fully resilient. No, it has not. Relaxation during hold, as the case may be, should not be mistaken for full recovery or full mechanical readiness to engage in other tasks. It has some of its own meaning, and that is what it should be interpreted in that context. I want to progress to bring us to an important issue because of this, what we call hysteresis. Hysteresis means tissue losses, of energy during repeated loading. The tissue loss of energy during repeated loading. And we see that a lot. If you look at this uploaded slide, hysteresis is defined as energy loss during the cyclic loading, stating that tissue dissipates energy as heat and becomes less efficient with repetition. Remember that walking, which is the movement of interest for us as movement scientists, comes in cycle. You repeat the same cycle of event. There was a time when you made initial contact with the ground, and there was a time when you made initial contact with your heel, and a time when you do a push-up with your toe. You do it in one cycle, then you repeat it all over again. Therefore, it means that the system experiences a cyclic projection of the body center of gravity on the ground. Because whenever you walk, the body center of gravity, which acts through X3, X4, that the force by which the center of gravity pulls you to the ground, which acts through the center of mass of the body, which is the mass of the body or the weight of the body times acceleration due to gravity, pulls the body to the ground, to the center of gravity, and towards the center of gravity means towards the ground, and that is what increases tendency to fall. Okay, so as you walk, that is what actually happens. There is a tendency to pull you to the ground, and as this is happening, remember that muscles also contract in order to hold back the body from being pulled to the ground. The muscular structure, the neuromuscular system, they are activated and muscles are contracted to provide vertical support so the system is not pulled to the ground. And therefore, it sustains the body in upright stance. Now, that contraction that helps to sustain the body in upright stance while accomplishing the translatory motion that is desired implies that energy is expended, implies that there is a metabolic cost to that locomotion. It implies that energy is dissipated, and it can be dissipated in the form of heat. And therefore, if you keep repeating this movement over and over, if you have to ask the person to repeat the cycle of movement, which starts from heel strike to push off, from heel strike to push off, from heel strike to push off, the consequent energy consumption continues also to remain in those cycles and are expressed likewise. But over time, that system becomes less efficient. It may be efficient the first time he walked 10 meters. But when you now ask him to repeat the 10 meters a second time, it may not be that efficient as at the first time. And you say, okay, work a third one. May not be as efficient as the second time. A fourth one, it comes to a point where that movement becomes highly highly distorted, that it will not be the same. It's not able to sustain that same movement if you repeat over time, because a lot of energy is spent on each occasion. You keep spending energy until at a point the body feels so weak and fatigued that it will not have the same quality of motion at the opting time. So this is one of the most important clinically unappreciated biomechanical ideas that we need to look at in the real rehabilitation world, because tissues that we find in our patients are often loaded repeatedly rather than once. So we believe that repetition enhances functional restoration, and patients learn when they repeat the skill. But that is okay. But what is the balance? The balance is that there must be a recovery. And if you do repetition without recovery, then a time comes when you switch the system totally in such a manner that the system begins to experience hysteresis. It's energy consumption, and that energy consumption becomes too much for the system to manage. Remember, I did mention that most of the structures in the human body that emphasize function deal more with power, which is work done over time. And because also most of those structures are structures that are third-class liver, and which emphasizes speed, emphasizes and prioritizes range of motion, and not without recourse to the forces that are required to sustain the loading. So over time, energy will be lost so much, and this energy that is lost is energy that is lost from repeated loading. So during repeated cycle, not all stored mechanical energy is returned efficiently, because you say that you convert energy from one form to the other. So those potential energy that you have that goes into mechanical energy and then that are transmitted into heat energy, not all of them are reconverted back again to mechanical energy or to the potential energy that you have at the beginning. Some of them are dissipated as heat, and therefore they are not returned efficiently back to the original position. If you sustain it over time, you must lose energy. So some of this energy is lost. That means that with repetition, the tissue system may become less mechanically efficient, and you must think in that situation and that direction, and therefore vulnerable to fatigue. The idea, therefore, is not that because repetition helps you to learn, you must be unmindful of the challenges that come with it, and which is hysteresis. I have mentioned some, like creep. I've mentioned hysteresis and the other ones. So this has the implication for functional training and for gait retraining and for plyometrics that we do in gymnasium and for repeated lifting and for endurance tasks and for return to play or return to sports programming. It also helps us explain why a patient may perform the first few repetitions very well, but gradually deteriorates in control, deteriorates in comfort, or movement quality. So the problem may not be initial capacity alone. The problem may go beyond the initial capacity of the patient. It may be the declining efficiency of the system, because across repeated cycle, the system becomes less efficient in managing energy that is translated from potential energy to mechanical, and in the process to heat energy, and then that drives the system in kinetic motion or kinetic energy. And then when you reconvert it back again, when the system comes to a stop, not all the potential energy that was initially there are still retained. Some has been dissipated, and that is explained by the phenomena of hysteresis. So in our settings, this is particularly very relevant when we are talking about patients whose occupation requires repeated loading, patients that load cement, patients that carry things from one point to the other and they do it repeatedly, patients that are at workstations where they need to package the shirts or package the dresses or package this or package that, that in essence they have to bend over and they load their system with the body weight in order to bring it up from the ground to package it on the workstation that is on a platform, and they need to do that from morning till night. Patients who have such occupation, who that require repeated loading, they have some problem. So if you have not done your clerking with the perspective of understanding the occupational exposition or the occupational status of your patient, your prescription may be faulty. Because what is a teacher experiences in this regard is not what somebody who loads cement, who does a lot of mechanical function, or a forklifter, is not the same thing that they do. So if you do not understand the nature of the occupation, then you will not be able to look at hysteresis. You not know the impact of hysteresis in the system for that patient. And making recommendations in your prescription will not follow the trajectory that movement science principles and rehabilitation would have deemed most accurate and relevant and useful to that patient. So you need to see that occupational requirements, that demand repeated loading of the musculoskeletal system, including traders, manual laborers, farmers, health workers like physiotherapists and nurses that keep carrying patients up and down, and caregivers. In such situation, in such setting, you must anticipate that over repeated cycles of their work schedule, efficiency in energy consumption and energy management will be declining. And if there are patients already, it will be aggravated. And if you're making a return to duty or a return to sport programming, you must factor that in and be sure to know whether this patient, who is a farmer, who is a health worker, who is a caregiver, is sufficiently recovered that he can manage these energy dynamics better. Otherwise, you have to be careful in recommending that the patient return back to work without putting caveats. A tissue may appear very capable at the start of the day, in the morning when the patient has come to see you. So you examine this patient in the morning, first thing in the morning. That tissue will appear very capable, or during your first session, the first patient that comes in there, that tissue will appear so capable. Yet, when you now look at that same patient, when he has exposed himself to cumulative loading activities of the day, it may reveal a true clinical limit. And that simply means that when you have patients who have the tendency to be loaded in this manner, and you need to make a decision about return to play, you may not need to give them early morning appointment. Because you otherwise, when you test their tissues in the clinic, you will not be able to see the impact of repeated loading and their ability to manage the energy efficiency. So such patients, you give them afternoon appointment, because in the other activities of daily living, they have engaged themselves. They will have loaded themselves sufficiently. When they come to your clinic and you now assess them, you have a better idea whether they are able to manage this or not. And therefore, whether the return to play or return to duty is optimized at that level of your treatment, and whether recovery has achieved that level that is desired, and what caveat you must put in the system. Otherwise, if you see them first thing in the morning, there may be a deception. I want you to have a very practical insight into this. And you begin to see that sometimes we have missteps and we take some of these things for granted. And sometimes we question ourselves, but this patient was looking okay. How come that this patient they say he fell, at work, he fell down again. But I assessed this patient, everything was okay. What time did you assess the patient? Did you look at the energy demand? How he's behaving to hysteresis? Because you gave early morning appointment, not afternoon appointment, so that you can see how the system is sufficiently challenged before you can make a decision of return to play. And I don't know how many of us have clerked a patient and said to the medical doctors that because of hysteresis, this patient should not go back to work yet, because I have done my assessment and is not able to manage the energy dissipation appropriately. Energy conservation and efficiency is very poor. So you think about that. And we can actually objectively measure this energy demand. We can measure it and how the patient responds. We can measure it, we can calculate it, we can quantify it using the equations of Ralston if we determine the velocity of walking over a given distance, over a given time in repeated cycles. And we hope that the hands-on session will give us that insight. And so if you're able to calculate the energy demand and put it in solid figure in your assessment note and say this patient consumes 30 kilojoules over a distance of 10 meters, repeated 3 attempts of it. In second attempt, he consumed this. Third attempt, he consumed this. Fourth attempt, he consumed this. This patient cannot sustain because as we go on, the ability to manage energy efficiently deteriorates more and across the entire spectrum by as much as a decline of 30%, 35%, 40%, then that patient is not consistent. You can't begin to return to play to stations where they have to subject him again to repeated loading. If you have to do so, then there will be a caveat. This patient must leave work by 12 noon or must leave from duty because you have made projections from your calculation how much the patient can tolerate before the system begins to misbehave based on your clinical assessment, and you have solid figures to back you up. But these are things we are not doing. And when we do things this way and write reports this way, you see that other practitioners begin to respect our decision because they are embedded in science. And this is one of them. Another part that is critical when we speak to the time-dependent behavior of tissue is the loading rate changes that tissue exhibits. The slide already highlights the loading rate by contrasting slow loads and fast loads. From the slide, you can see that slow loads are associated with controlled movement. Controlled means that you deliberately unload. You are not loading the system at the rate it should be loaded. Therefore, you are unloading actually. And you reduce, you can also have that slow load when there is reduced stiffness. Therefore, when the body is so flexible, like when you have stabilization issues, when you have stretched, the knee joint stretched, the elbow joint stretched before a high stabilization tax demand, then you have to know that in such situation, when you need to load such joints you have stretched, you need to do so slowly. Only slow loading can work, nothing more. Anything outside of that will lead to injury, and you must be mindful of that. So slow loads are associated with controlled movement or reduced stiffness, or they are also associated with lower injury risk. Because when you load slowly, the injury risk is limited because you give the body enough time to adjust and to manage that load in such a way that damage is not done by, either the viscoelastic properties being stretched beyond its limits. So whereas fast loads may increase stiffness and injury risk, because when I put on a heavy load on your head, quickly your body stiffens up. And when it stiffens up, it contracts and increases the demand, the force demand, to respond to the external force that is applied. And that contraction may involve tissues that are already injured. That contraction to stiffen the body will increase injury risk in the system. Therefore, you need to know when to do slow loading and when to do fast loading. The deck itself you are looking at also states that rehabilitation should progress from slow loading to controlled movement to faster task, so that way you avoid injury to tissues. So the principle is essential in exercise prescription, especially in prescriptions involving movement of all types. Two exercises may appear identical in their joint range of motion that are associated with them. They may appear identical in the loading, the exact amount of load. But if one is performed slowly and the other one is performed rapidly, the tissue demand changes substantially. The same exercise with the same load, 5 kg load, the same range of motion that you need to move your elbow, 30 degrees flexion or 45 degrees flexion, carrying a 5 kg dumbbell. It is the same exercise, it is the same load. But the moment I say, do it fast, faster, and I use a metronome, which I have set at a particular frequency that is faster than while the other person is doing it at a slower rate using another metronome that is set at a slower frequency. The one doing it faster and rapidly will have a different biomechanical experience from the one that is doing it slowly. So you are loading up the system fast or you're loading up the system slow, they have substantial impact. And one of them, those that loads fast, they stiffen the body and make it prone to injury. And those that load slowly, they do not stiffen the body. The body is less stiffened and they can absorb and adjust, and therefore are associated with less injury. So fast loading increases challenge not only to the force production, it increases challenge to coordination, it increases challenge to timing, and then tissue tolerance that is required to accommodate that load. The tolerance becomes so challenged in a very short time. So this is why progression in rehabilitation is not simply about adding resistance. No. Progression doesn't mean you must move from 5 kg to 6 kg and from 6 kg to 7 kg. That is not progression in rehabilitation context when you think as a movement scientist. Progression is also about introducing speed at the right time. So you can use fast loading to enhance progression in your management, and not necessarily 5 kg, moving it to 6 kg or to 10 kg. You may retain the same 5 kg, but in the next progression, you say do fast loading and you state the duration of loading using a metronome count. So this has clear relevance in neurological, in musculoskeletal, and of course in sports rehabilitation, as most of us already experience this in our practices. So if you have a patient with tendinopathy, he may tolerate slow, heavy loading, but that patient may not tolerate fast stretch, shortening demands. You know, a patient who have or who may have gone through, excuse me, anterior cruciate ligament reconstruction. That patient may show acceptable squat mechanics. When you ask the patient to squat and then to to stand from squatting, he may have and demonstrate very acceptable squat mechanics at very slow speed if you do it slowly. But the patient will lose control when you now say do it faster, because that faster will require faster deceleration. You see, as you are doing squatting, he is being conscious of the injury, the anterior cruciate ligament reconstruction, because he's still recovering. And he needs to decelerate the force of gravity, pulling him down into squatting position. Because you are saying squat faster, deceleration needs to be faster. In such a situation, that patient will lose control and fall, and sometimes may damage the same reconstructed anterior cruciate ligament. So in such kind of situation where you have ACL and where you need to do squatting, it must be slow for these reasons until the capacity is sufficient to sustain faster deceleration, which is demanded in that activity. Otherwise, there will be problem. An older adult also may manage sit to stand very slowly. When you tell mommy stand up from sitting, stand up, you can do so slowly. But when you say you increase it and and then you want the older adult to continue, no, the patient may fail when speed is required for balanced recovery. You see? So for expert practice, loading rate should therefore be treated by us as formal prescription variable, not an incidental detail, not something that, okay, yeah, loading frequency is one of those things. No, it is part of our formal prescription. We should make it part of loading rate because it influences the tissue behavior. Remember, everything we do in rehabilitation is that we try to use biomechanical modalities, movement science, to make the tissue adapt to a different loading experience that has therapeutic value, both in terms of restoring the form and the function. So that's all we do. But we must see also that these properties of tissues are recognized in our prescription. When we look at hysteresis, when we look at a creep, when we look at situations that deals with loading rate and its consequences, so we begin to see that this nature, this behavior of tissues must be considered in our prescription. So if we have not considered them, then we will not be thinking properly. Our clinical thinking, our clinical reasoning, our rehabilitation reasoning will sometimes be faulty. So it is not about introducing resistance. It's about introducing speed at the right time. And it has very clear relevance, and we must acknowledge it. And as practitioners, we need to also know when to use them as prescription variables, formal prescription variables, and not just as an incidental detail that we can latch on to just for the fact that we want to describe it more in. No. The sixth property of tissues, which is how they behave, is fatigue. There is tissue fatigue. It is a very core clinical concept. And I know we try as physiotherapists, occupational therapists to consider that most of the time. It's not a secondary behavior. It's a very core clinical concept. It's primary. For us as rehabilitation scientists, we must always recognize that. And that is what we have framed in the slides. We identify tissue fatigue as a critical concept and define it as the accumulation of micro damage under repeated loading. Accumulation of micro damage, very small damages of tissues under repeated loading, contributing to overuse conditions. So there are overuse conditions which are fundamentally informed by repeated micro damage, accumulation of micro damage resulting from excessive fatigue or fatigue of the tissues, as the case may be. So what we try to state here is that recovery is part of prescription, and we must acknowledge it. We must always acknowledge that tissues need to recover when they are loaded. because when they are loaded, we are increasing the tendency to fatigue. We must also, in our prescription, demand that these tissues recover after one cycle of loading before the next cycle of loading happens. So tissue fatigue and the recovery now should be part of our prescription consideration, because we need to think in that sense as movement scientists. It's part of rehabilitation reasoning. If you take a look at the slides, it goes on to show that fatigue affects movement timing. Fatigue affects coordination. Fatigue promotes compensatory strategies that are not the normal form of movement execution, and then increases injury risk as a result of that. So you see that there is a need, therefore, to prescribe recovery when interventions are prescribed. Alongside these interventions, recovery should happen. You may say, do this 1 minute, rest for 2 minutes. Do it another minute, rest for another 2 minutes. What you are allowing for and what you are seeing in that prescription is that the prescriber is thinking like a movement scientist. Is injecting recovery of the tissue because of the quality of the tissue, the behavior of the tissue to fatigue under loading. If you don't factor that in your prescription, then the patient may be at a greater risk of injury. So this may not be the most clinically significant part of this module, but fatigue is often treated casually in rehabilitation, as though it is simply a subjective compliant or a subjective complaint from the patient, or just a sign that the patient has worked hard enough. No, it's a sign that what you have prescribed is injurious and you have not factored in the recovery time. And the pension system demands that there should be adequate recovery. So, but biomechanically, fatigue changes movement quality. And you must recognize that. It alters timing, it alters degree of coordination. And therefore, it redistributes the load in a way that may increase tissue stress because of that fatigue. So this means that repetition quantity alone cannot define a successful session that you have given a patient. A patient who actually completes a target number of repetitions of a movement task with deterioration or deteriorating control may not have completed a very productive session as such, because there is a deterioration in the control of that movement as a result of fatigue that sets in. The quality is poor, and whenever the quality is poor, you cannot say that the session is productive, because ordinarily you do not function in fatigue zone where the productive where the movement pattern or the movement output is born out of weak fatigue or energy loss. So they may instead have crossed from adaptive loading when they are fatigued, because that fatigue triggers redistribution of loading in a pattern that shows and reinforces the deteriorating control. So the loading is redistributed in a manner that is not sufficient to replicate that motion in a high quality way. You damage the tissues and you push the system from adaptive loading into maladaptive loading or maladaptive compensation. This is especially important in Nigerian context, because sometimes we don't have patience when dealing with our patient because of the volume. All we just do is, well, you start doing this, you start doing that, you start doing this. You are treating 5 patients at the same time, giving almost zero attention to some of these important details. and the consequences affects the recovery of our patients. So in Nigeria, this is very important, where rehabilitation sessions may be compromised. They may compress these rehabilitation sessions into very short timing because of number of staffs that you have. You maybe be the only physiotherapist, so you just do bah, 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 bah. So do this loading, do this loading, do this loading. You don't give time for the patient to recover. 5 minutes, whereas that thing should be done in 15 minutes. So sometimes, are we helping the patients? And we still wonder, their injury is exacerbated. Why they hardly recover at the rate we expect them to? Whereas we adopt as the approach. How can you be? And as movement scientists, we need to begin to rethink these things. The has consequences. You see it as but the patient system sees it as harmful. It damages their system. Have you thought about that before? That's why this workshop is important. So we can have conversations around this and make you understand that these biomechanical principles have direct implication in function and in treatment procedures, and in therefore clinical reasoning demands that when we prescribe and implement our prescriptions, we are fully guided by such biomechanical principles and a deep understanding of the behavior of tissues. Either we are looking at their behavior in their viscoelastic properties, or in terms of creep behavior, or in terms of how they behave with loading rate, and now we are looking at how they behave as systems that can get fatigued and the consequences of it. For us, where we have limited physiotherapy resources in terms of personnel, and also when we prescribe home programs for them, what they may do at home without close supervision, the kind of education we must give them to emphasize why they must always give time to rest and recover before they do the next. It is not a measure of how strong you are. Because, local African man believe that when you do it consistently and you apply muscle, yes, you shows you're a man. But you need to now re-educate them. It's not a man issue. There is impairment in the system. The system will easily go into fatigue and then redistribute the load in a manner that we push the system into maladaptive strategies that continue to emphasize fatigue and expose the patient to risk of more injury. So you need to educate them how to perform home programs that are unsupervised. Experts need to teach not only efforts, we need to teach movement quality under fatigue. So we don't just teach our patients the kind of effort they should make in executing our prescriptions, our movement prescriptions, our exercise prescriptions, but we should teach them the quality of movement that they should sustain under fatigue, and the quality of movement they should never, ever sustain under fatigue. So once they are fatigued, then everything has to stop until they are sufficiently recovered. So recovery intervals becomes a critical part of prescription. The total volume, recovery interval, and the symptom response that you see in these individuals must be considered as part of your intervention design. And I don't know how many intervention designs we have already created where we emphasize recovery interval and volume of intervention and the symptom response that must be considered in that interval design. So once you have this symptom as a response, this is what you do. And this is part of our prescription. When you have this symptom, then you can do this. You can do this much volume. But when you have this symptom, including this fatigue symptom, don't do this. Do it this way. These are things we need to to do as movement scientists. This seventh principle that I want us to consider under this second module is that we need to have an understanding that fatigue alters movement control before obvious failure appears. And therefore, we should not be thinking that until failure appears, there is no fatigue. No. Or until failure appears, the movement control is intact. No. Before even the failure appears, movement control has actually been subjected to serious decline. So the presentation states that the fatigue affects timing, affects coordination, and it causes movement to become compensatory, and injury risk now rise as a result of that. You see? So this is a very valuable teaching point because it shifts attention from viable collapse or visible collapse that we see to something that can happen much earlier. It shifts attention to subtler deterioration. So we don't have to look out for very visible collapse before we get worried. Rather, we begin to understand that there is a subtle deterioration in control, which happens before a visible collapse is presented in this patient. So in many rehabilitation contexts, the patient does not really suddenly stop. Instead, the signs of overload emerges as altered timing. You now begin to see that their timing of flexion, extension, flexion, extension, flexion, extension, flexion, extension, flexion, extension, flexion. You see, the timing has changed now. This was a patient who was doing flexion, extension, we're using the lump boot, flexion, extension. All of a sudden, you now begin to see flexion, extension. He has not collapsed, but the timing has already changed. It is a serious warning. It's a serious landmark. It's a sign of overload because overload signs are now beginning to emerge about altered timing, about trunk substitution, because now the extensors of the knee are now becoming fatigued. Therefore, there is now a substitution using the trunk muscles coming to do the job in a compensatory drive, no longer the extensors that the patient was using before. And you begin to see reduced range of motion as a result of that. You see increased stiffness, the body becomes stiffer, and therefore more contraction of muscles, which damages the already weakened or injured structures like ligament, tendons, and so on. And you see asymmetry. It now begins to bend to one side in order to gain more force from that abdominal area or from the trunk region. It may lean to the left instead of the previous balance symmetry of the trunk in a sitting position. And then it tends to have slower reaction. So when you begin to see this, you don't wait for collapse. There is already a sign preceding the eventual visible collapse. And therefore, the signs of deterioration emerges from poor timing, poor coordination, and then compensatory drive, which becomes more obvious. All of this happen before a fatigue-linked collapse occurs, and therefore you don't have to wait for that collapse to occur. When you see the change in timing and coordination, you know that this person is entering the region of fatigue-linked collapse. You have to step in. And you must identify these things yourself, document these things in management, and educate the patient properly in this direction. Because otherwise, the resultant impact is more injury instead of recovery. So patient has come to you for recovery and has left with more injury. Remember, you took an aristocratic oath that you do no harm. Rather than do harm, leave the patient as it is, as the patient is when you meet the patient. So you are violating that oath. You are doing harm. It's unethical. But sometimes we do it out of ignorance because we do not pay attention and we do not have a deep understanding of the behavior of tissues that we are subjecting to movement. We do not understand it. Now, this is what the course, biomechanics and kinesiology, put together under movement sciences with gait analysis ought to do for you. But then, where we are taught in our schools, do not bring this clinical reality. We are taught as if we are training engineers, as if we are training physicists, whereas we are training healthcare practitioners, we are training physiotherapists, occupational therapists, where these principles have sound clinical implications, but these are omitted and these are not leveraged. And some people don't even see the need. In fact, I was among very senior colleagues some years ago, and they were arguing during accreditation that biomechanics and kinesiology and movement science have no value. They don't see the value of it in practice. And I really, really understand them. I was not shocked. It's not a fault, no. But it's because we do not have opportunity to be exposed to the true principles of these things and to have a deeper conversation on their relevance. And a workshop like this, organized by MRTB, affords us that conversation. And I'm grateful for it, that we will live here thinking like movement scientists. We will live here thinking more like proud practitioners who are going to harness all this knowledge and competencies, especially clinical reasoning, as a very valuable tool that we can leverage in low resource settings where we don't have equipment that does all these measurements, but we can think right and get the same result, get our patients to recover well without doing harm to them unintentionally. So for expert clinicians, this means that fatigue should be identified not only by the patient's report of tiredness, but also by movement science itself, the movement that the patient produces. When the movement becomes, the quality becomes distorted, the timing, the coordination becomes poor. Those signs may include loss of eccentric control, increased trunk lean when they lean to one side of their trunk, which was not happening at the beginning of that movement, or when do you see them have reduced push-off, or when you see them have shortened step length, or when you see them have reduced pelvic control or protective co-contraction, then there is a problem. Sometimes you will see old patients lean towards the right foot, and you think that it is guy. It's not guy. They have a problem. It is speaking about fatigue of the muscles on the contralateral side in executing that function that warranted it. So whenever you see a patient leaning on one side of the trunk or leaning on and over a foot when walking, there is weakness on that side of the trunk. There is also fatigue, and that is not good. You can correct it. So the presence of these changes will tell you, and of course, all of us, that tissue and motor system are no longer responding to load in the same way as they did at the beginning of the task. And this has a clinical meaning. This is clinically meaningful. Let's look at the clinical applications. When we talk about stretching, tendon rehabilitation, return to play, of all of these things we have already gathered now about the tissue behavior, a time-dependent behavior of tissues. The slides we have seen makes a very strong effort to communicate to us that these concepts have clinical application. There is a meaning For stretching, there is implication for tendon rehabilitation, for return to play, as direct areas where viscoelastic behavior and fatigue should matter. So when you are looking at stretching, tendon rehabilitation, return to play, viscoelastic property and behavior of tissues and fatigue of tissues should matter. Remember, these are time-dependent qualities. So in stretching, creep, and stress realization, they help to explain why prolonged or even graded approaches can increase the range of motion of joints in patients. But beyond that, they also explain why timing, why the context, why stability, status of the person matters a lot. So in tendon rehabilitation, time-dependent loading is also fundamental, because most of you who work in orthopedic hospitals, we know, and who have managed it, we see that tendons are not only load sensitive, tendons are also rate sensitive. So loading rate, not just load sensitive, but loading rate sensitive. So whether you load slowly or whether you load fast, and then repetitive sensitive. So when you repeat it severally, the same loading, and repeat it severally, they can the tendons will respond very sensitively to that. So you have to be mindful. So therefore, rehabilitation depends on careful progression of loading magnitude, progression of speed, of frequency, and then recovery. So because it means the longer the repetition, the longer the recovery time you give between repetitions. So if they start initially, you may do 2 repetitions, you rest for 1 minute. You now do 5 repetitions, you rest for 3 minutes. Then you do 7 repetitions, you rest for 4 minutes. Then you do 8 repetitions, you rest for 7 minutes. You see that as I'm increasing the repetitions, I'm also increasing the recovery time. But you see a situation where we ask the patient to do 2 repetitions, 1 minute interval rest. Then you do 5 repetitions, 1 minute interval rest. Then you do 6 repetitions, 1 minute interval rest. That is wrong. But we do that because it is wrong, because the nature of the tissue, the behavior of the tissue does not support it. And therefore, it is something that we must actually stop. And I'm trying to lay this foundation before we come into gait analysis properly. Because if we don't understand all of this in movement, then everything goes haywire. So in return to play, you see that athletes must not only demonstrate capacity under loaded conditions that we normally subject them to, but we also want to see them maintain movement quality under repeated and faster loading. So we just make that decision that they should are free to return to play because we have loaded them and they have responded adequately. The muscle strength is there. But have we examined the quality under repeated loading? Have we looked at faster loading? And that is why I said that making such a decision, you don't give the patient appointment in the morning. You give the patient appointment in the afternoon. So you will have loaded the system properly before coming for a clinical assessment, and you now further challenge the system. And then you look for timing, look for coordination and tolerance. So tolerance in the first repetition is not enough. You tolerate the first repetition, tolerate the second one, it's not enough. The real question is whether control is there. The real question is whether load distribution is in such a manner that supports adaptive strategy, or does it support maladaptive strategies and performances are sustained over time. So these applications are highly relevant in Nigeria to us, because when we handle athletes, when we deal with workers, when we deal with patients over return to play or return to work demand, we should be careful because of economic or social pressure. we should be careful that they may be enthusiastic, but their system may be less enthusiastic. And we therefore have to do the proper assessment so that we don't get ridiculed. And they say, but the physiotherapist get clearance for you to resume. Why is all this happening? Does it mean that he doesn't know what he's doing? In a way, we ignore some principles. So expert rehabilitation must therefore include practical strategies for graded reloading, not only symptom reduction. And that is very important for us. I would finally look at rehabilitation logic for time-dependent load and the dosing in that manner, and connection to us as experts in movement science. Here we are trying to say that conscience clinical decision framework, it assesses tissue state, it prescribes the appropriate load, it monitors responses that follow as a consequence of this loading, and then monitors the progress the patient makes systematically, while also considering the creep qualities of the tissue, the stress relaxation properties of the tissue, the fatigue properties of the tissue, and the transition from slow control to faster controlled loading, which means more demanding task, more loading demanding task, how the tissues behave in that sense. So the framework is sound and worth emphasizing. First, we assess tissue state, and that is to say, we ask questions on what is the likely irritability of the tissue, what is the healing stage of the tissue, what is the tolerance of the tissue. We further ask questions on, is stability a concern in this system or not? Is repetition provoking symptoms more than peak loading will provoke symptoms? The second logic in our reasoning, in our rehabilitation reasoning, will be to prescribe appropriate load, not just how much should be our question, but how long, how often, and how fast should those prescriptions be implemented. Following from all these assessments, the third logic in our management approach should be to monitor the response. And in doing so, we should ask critical questions. We should ask ourselves, does this patient improve with exposure to loading? Or does he deteriorate with the repetition of this loading based on my prescription? Does movement quality stay the same? Does it stay stable? Or does it deteriorate over time in terms of timing and coordination? And if it does, you already know the answer. And the fourth logic that will come in your management and prescription will be to look at progress systematically. You know, you need to know what to do in that area. Do not move to faster or more cyclic tasks simply because pain has reduced or pain has been minimized. Progress to faster ones when the tissue response and movement control justifies it. But when they don't justify it, please do not progress. This is the heart of expert dosing. So if you are doing a load dosing, the question that must drive you, the principle that must drive you is simple. Do not move to faster or more cyclic task simply because that pain has minimized, that pain has diminished, that pain has reduced. Always know that you can progress when the tissue response and movement control justify it. If they do not justify that, please don't progress. It has implication. All that we have said today have implication for rehabilitation practice in Nigeria. Because for us as rehabilitation experts, this second module offers us several important practice implications, which I want us to reflect on. I think it reminds us that tissue behavior is dynamic and it is not static. So the tissue behavior changes with time. And so when we're making prescription, we should be looking at how it will behave with time. That is why one of it is to increase the interval of rest as you increase the repetition cycle of loading, which some of us do not do in our prescription because we do not understand that this tissue behavior is not static, it is dynamic. So as time goes on, more fatigue will set in, creeping will set in. Everything about the tissue behavior is time dependent. Therefore, recovery you must give when you increase the loading repetition cycle must also increase progressive manner. So symptom-free initial performance does not really guarantee that repeated load readiness is achieved. No. If you do the first one, and the performance was symptom-free, it doesn't mean that there won't be symptom in the next one. Therefore, you need to be careful and you need to monitor all these dimensions before you can be sure that you made the appropriate prescription. So it teaches that recovery is not an optimal luxury, and it's not an optional luxury for us, for a patient. Recovery is not just an optional luxury that can happen when they are receiving treatment. If they are lucky, they can recover. No. In many patients, poor outcome actually reflect the interaction of loading and insufficient recovery, rather than inadequate effort on the part of the patient. It is because the physiotherapist, the occupational therapist, the biomechanist, the movement scientist, they are overwhelming the system. They do not understand the tissue response to loading, and therefore they give inadequate time to recover. And they attribute this failure of recovery of the patient from this impairment to the lack of effort on the part of the patient, whereas it's not true. It is because we do not understand the time-dependent behavior of tissues, that is not static, is dynamic, and we are not harness and leverage that as movement scientists to deconstruct the injury and then help the patient to recover. So it supports more intelligent home program. What we have done so far, it supports that the patient should not be told only where exercise or what exercise the patient must do. That's not what you must tell the patient when you are giving them education. You must tell them how long to hold these exercise sessions or prescriptions, and how many repetitions to perform, and how fast they should move, and when to stop based on quality and symptoms that they have experienced. Can you take a look at your home program in movement prescription and tell me if you have put all of this together? Now, this is the logic of rehabilitation. This is the clinical reasoning behind movement science. And this dovetails critically into the how our patients recover and why they do not recover. So this approach will improve communication within a multidisciplinary team, because you are communicating to the physician, you are communicating also to the ergonomist, you are communicating also to the occupational therapist, you are communicating to the biomechanist, you are communicating because they speak the same language, they understand what you are saying. And that's why I love what MRTB did. He opened up this workshop not to physiotherapists alone, opened it up to rehabilitation therapists. So we have here a multidisciplinary team that have a common convergence goal of patient recovery in terms of form and function and independence, self-driven, interventions. But who must receive the appropriate education and who must guide them with the appropriate principles of biomechanics, which we sometimes and sadly do not appreciate because of the way we were taught, and we do not harness them in making our decisions. So if you see that, if you have this understanding that what you tell the patient, what you prescribe to the patient, what patient should be told will not be what exercise to do, but how long to hold that exercise, how many repetitions to perform, how fast to move, and when to stop based on the quality and the symptoms that the patient experiences. Then, because I'm speaking the same language, the moment an orthopedic surgeon sees what I have written, or when an occupational therapist sees what I have written, or when a biomechanist sees what I have written, he understands what principle I'm working on. I am considering the time-dependent behavior of tissues, and that is solid. And he will not have a doubt, but to build on that principle in his own aspect. When the patient comes for occupational therapy, he is emphasizing the principle that I have already initiated as a physiotherapist. And when the patient goes to see an exercise physiologist or an exercise scientist, he is also building on the principles I've established as a neurophysiotherapist who understand biomechanics of movement. You see? So there is a continuum of care around that thought flow, and therefore it improves communication within the multidisciplinary team, where the surgeons and the physicians will always ask questions, they may not know it, and the physiotherapists will be able to say the same thing. The exercise therapists will say the same thing. They will guide the patient recovery. Likewise, the occupational specialist. All of these can benefit from a shared understanding that tissue response changes across time. A tissue response changes with repetition. The tissue response changes with loading rate. Above all, this module helps us to avoid one of the most common rehabilitation errors that we make in our climb, assuming that because a tissue tolerated a task once, it is ready for the full repeated demand of life or of sports or occupation that the patient is exposed to, or that the patient employs in activities of daily living, either for livelihood or for leisure. And so here I end the second module. We can take some questions, and then we take a 10-minute break and come back for the third module. My concluding remark, based on what we have seen so far, is that this module teaches us very important rehabilitation truth. Tissue tolerance is not static. It changes across time, changes across repetition, changes with speed. And all the slides you have seen so far summarizes that clearly. They all state that tissue are time dependent in their behavior, and that load plus recovery must be managed by the therapist. You must manage them with viscoelasticity informing safe progression, so that everything happens in a tolerable limit. For us as experts, this means that the quality of rehabilitation that we provide our patient depend not only on choosing the right exercise to give them, but on dosing it in time. We must dose it in time. We must dose it, again, I repeat, we must dose it in time, because the tissues that respond to them are time dependent. So we must think beyond what movement is required by this patient. What exercise in movement are we going to ask him to do or ask her to do? We must go beyond it to ask, how long is the tissue loaded in this prescription? How many times is it loaded in this prescription? How quickly is it loaded in this prescription? What happens to control as fatigue develops? And has sufficient recovery been built into the treatment plan? Not when you now see that you have 50 patients, you now give high brigade treatment. Do it intensive physiotherapy, intensive. Do it immediately. Do. Oh, goodness gracious me. At the end, you say, even though we gave intensive physiotherapy, we didn't see recovery. I don't know, the man is not making effort very well. You are talking like a clinician. Now, these workshops are forced an opportunity not to do that anymore. Because that is the difference between generic exercise prescription and expert rehabilitation reasoning. That is why the board has been emphasizing on different domains of development. Clinical reasoning is the reason why you have DPT program, and that is why it's highly different from the other generic program, BMRPT, BPT, and so on. And if as scientists, we don't have it, what we have is just generic exercise prescription, then we are at the same level as technicians. But what makes us expert rehabilitation scientists is because we have deep clinical reasoning and reflection, or understand the principles and we apply them as principles of movement science. And that is what this module has brought to bear. And I hope that we have learned something from this one. All these are going to cumulatively build into clinical gait analysis. I choose not to dive into clinical gait analysis like I normally do because I realize that we lack the understanding of the basic structures and the support system that drive that process of gait pattern and gait understanding, because we don't have these basics, and I have to go back to them. So that by the time we now switch gears into movement analysis, gait pattern, and so on and so forth, you will now begin to appreciate it the more. So this is where I give you 10 minutes more to rest and relax your brain, stretch yourself. But remember, when you stretch, don't put too much load, especially when stability demanding task is what you will perform next. I'll see you in 10 minutes. All right, welcome back to the module 3. And I hope that the module 1 and 2 has been informative, as we are laying foundation to progress in our clinical gait analysis workshop. In this module, we are going to be, I hope you can all hear me. I hope I can be heard.
Loud and clear, sir.
Okay, great. So in this module, we shall be looking at an important thing that also contributes, but which we often neglect in movement science as movement scientists, and when we prescribe movement as interventions, or when we do remedial or retraining, and that is the stress strain behavior and muscle function. What is it all about? We're doing this for a reason, because we want to explain and to know, gain insight, how tissues respond mechanically to loading, and then how muscle function changes across length and velocity conditions, and how these principles actually guide injury interpretation and rehabilitation planning and exercise or movement prescription. And so it is important we have some lead on that. In Module 1, we established that rehabilitation is fundamentally about force, about torque, about mechanical demand. In Module 2, we extended it further by extending our understanding by showing that tissue behavior is time dependent, shaped by duration, repetition rate, and recovery. So in this third module, we move into one of the most clinically decisive areas of rehabilitation biomechanics, and that is stress strain behavior and muscle function. At the center of today's discussion in this module 3 is a simple but powerful idea that tissues do not fail randomly. No matter what you do, they don't fail randomly. They respond to load in a predictable mechanical ways. So they don't just fail. Tissues normally respond to loading. They don't just fail haphazardly. There's a reason. There's a pattern. And that those patterns are predictable. So they behave in a predictable biomechanical way. And those responses differ from tissue type to tissue type. The way one tissue responds to loading is different from how the other one responds. They differ in their tissue types, that is, the responses differ according to tissue types. They also differ according to the loading region, because they are different loading regions and they have different features. And then they also differ, the responses differ according to function or context. If you take a look at the slide, we understand and see what I mean, because we try to explicitly frame in that slide the stress strain curve as a basis for rehabilitation strategy that we provide when we make decisions as movement scientists, by identifying in that stress strain curve a very important region we call the toe region. And after that toe region, we have the elastic region. And after the elastic region, we have the plastic region. And after the plastic region, we have the failure region, while also emphasizing that tendon, ligament, muscle, and bone, they all behave differently. and therefore they require distinct rehabilitation logic. Now, this is precisely the reasoning that is required by experts in rehabilitation. So when you have a patient present with tendon pain, with ligamental injury, or with muscular dysfunction, or with impaired bone loading, impaired bone loading tolerance, for instance, our job is not only to name the tissue that is affected. Our job is to understand what loading region that tissue is operating in. So we can't just say this is as a result of an injury to the tendon or to a specific ligament or to a specific muscle. Those are the specific tissues that we can name that were affected by a particular incident, injurious incident. So we can name those injuries for all we can. However, our job is not just to name the tissues that are affected. Our job is to understand also what loading region that tissue is operating in. What functional consequences follow as a result of operating in that loading region? What form of rehabilitation loading is mechanically appropriate for that tissue in that region that is operating in? This is especially very relevant in Nigeria and to us in Nigeria, where many patients continue occupational or domestic or sporting demands despite pain because they need to fulfill obvious biological roles and necessities. They need to put food on the table, especially when the pastor or the clergy reminds them that a man who is not able to provide for his own home is worse than an infidel. And therefore, they walk through pain to make sure that they meet the occupational needs that will put food on the table. The woman will walk through pain to make sure that the domestic needs that will keep the home running are met so that he will be regarded as a good wife and not failing the husband and the children. And the athlete will want to do all things to ensure that the sporting demands for greater performance and excellence to win a trophy is achieved despite the pain, despite tissue irritation or incomplete healing processes. Athletes do this, workers do this, and so on and so forth. So in such context, as Nigeria, where this is a regular occurrence, then rehabilitation must be based on very sound biomechanical reasoning rather than symptom labels alone. So you don't just label the symptoms this way or that way. You go deeper by looking at the biomechanical reasoning that will drive rehabilitation process and procedures in such instance. So we aim in this module to explain the relationship between stress, strain, tissue failure thresholds, and then muscle performance. And the view is to translate these concepts into clinical rehabilitation decisions that are meaningful to the patient and that can undergird the implementation of the planned intervention by the physiotherapist. So the core scientific content of the model includes the stress-strain behavior of bone, tendon, and muscle, then the muscle force length and force velocity relationships, the injury thresholds and the functional consequences thereof, a case workshop that compares tendinopathy and ligament sprain on mechanical and kinesiological grounds, maybe a case-based routine analysis as continuous assessment, which maybe you will present in your groups on Monday. But let's look at the scientific content. Let's look at stress and strain as the core mechanical language of tissue loading, because that is what it is. Now, to understand tissue behavior, we begin with stress and strain. What is stress? Stress simply refers to the internal force distributed across a tissue area. Stress refers to an internal force distributed across a tissue area. This is different from strain, which refers to the amount of deformation that is produced by that stress. So stress is the internal force distributed across a tissue area, whereas strain is the amount of deformation that is produced by that stress. In simple clinical terms, stress simply tells us how much internal mechanical demand a tissue experiences in a given condition, while the strain tells us how much that tissue changes in its shape in response to that stress. The importance of this distinction is very obvious and enormous because two patients may appear to receive similar external load, yet their tissues may experience very different internal stress and strain, which depends on the property of the tissue, which could actually be a ligament or a muscle and so on. So it depends on alignment, depends on the tissue property, depends on the injury status of the patient or the muscle activation and the movement strategy. This is why rehabilitation cannot be reduced to external resistance alone. From the slides, you will see that we have the stress strain curve, which we showed earlier, as a central model for understanding this relationship. And then for identifying when loading, promotes adaptation versus when loading now risk, a damage. Now, if you look at the stress strain curve, it explains adaptation, it explains damage, it explains failure. The slides presents a classical stress strain curve in 4 clinically important regions. You see that there is a region 1, which we know as the toe region. Then we have next the elastic region. And next to it is the plastic region. And then thereafter is the failure region. So there are 4 key regions: the toe region, the elastic region, the plastic region, and the failure region. This is one of the most important conceptual tools we apply in rehabilitation biomechanics because it allows us to interpret loading, not simply as this is a safe loading or unsafe loading, but we interpret it as a spectrum of tissue responses. And those responses will vary according to these regions of either the toe region, elastic region, plastic region, or failure region. Now, if we are looking at the toe region, from the slides, you simply describe the toe region as the phase of safe early loading. that phase of safe early loading, where the collagen fibers are uncrimping and the risk remains quite low. So clinically, the toe region corresponds to low-level loading that begins to engage tissues without imposing major structural threat to those tissues. That is to say, it's often the loading zone which we use in early, reintroduction to movement after people have suffered from movement dysfunction, especially where pain or irritability is high. It may be appropriate for early tendon loading, protected ligament loading, or initial isometric and low range exercises. The toe region may be the appropriate region to make those interventions. The key point is that this region is not functionally demanding at all. It's not demanding enough for advanced adaptation that is required to improve function. But it is often valuable for restoring confidence in the patient, for restoring neuromuscular engagement, for restoring early tissue stimulus. You see, the elastic region is the next one to it. So after the toe region, we have the elastic region, and it is identified as the area of reversible deformation and the optimal training zone for adaptation. So normally, the elastic region is where we have the optimal training zone. We wish to train athletes there, train patients there, especially when they are injured and being managed by physiotherapists, occupational therapists, and other therapists in the rehabilitation sector. This is the most clinically important rehabilitation region because it represents loading sufficient enough to stimulate tissue adaptation without causing irreversible structural damage to the tissue. So when rehabilitation is well designed, much of our loading work aims to operate within this region. In this region, the tissue is challenged enough to remodel, it is strengthened and become more resilient, but not so far that we exceed safe mechanical limits that we should not exceed in trying to pursue the goal of the treatment task. For expert clinicians, this means that the elastic region is the ideal conceptual target that every physician or every therapist should focus on for most progressive exercise prescription that we make. And the next to it is the plastic region, which is described as the point at which irreversible structural damage to the tissues begin and micro failure begins to occur at the plastic region. So clinically, it is a danger zone in rehabilitation. Once loading repeatedly enters this region, then tissue may no longer recover to the optimal state, while very controlled exposure near the upper limits of tolerance may sometimes be relevant in advanced conditioning, in injured or in healing tissues, and maybe in repeated entry into the plastic zone. There is a risk aggravation, delayed healing, even frank breakdown. This is especially relevant. If you look at patients that return to high demand too quickly, high demand job or high demand tax, or continue unsupervised loading in their exercise prescription or home program, or muscle that is not properly exercised or loaded, where there is a mistake, or where you mistake reduced pain for restored capacity. But next to this plastic region is the region we call the failure region, which is clearly identified in the slide, indicating that load has definitely exceeded the tissue capacity at this point. So the region represents very overt structural failure. In rehabilitation, the goal is obvious. We try to avoid loading that pushes vulnerable tissues into this range. But the deeper lesson we get from all of this is that failure is not always sudden. Failure, rather than being sudden, is slow and steady. Repeated, sub-failure loading occurs near the plastic zone and may progressively move the tissue closer to the failure zone over time. So it is from the plastic zone that sub-failure loading begins. Repeated sub-failure loading begins within the plastic zone and then brings that tissue to the failure zone progressively. So tissues themselves are not mechanically interchangeable. So you must know what works for each tissue in terms of their biomechanics. A particularly strong feature of the slide is that they emphasize tissue-specific differences. So you will see from the slides that tissues are not interchangeable in any way, and that each one demands a distinct rehabilitation strategy based on its mechanical and biological properties. And that is something that we need to recognize because it identifies the following broad tissue characteristics which you need to consider in each circumstance that you find yourself. For the tendons, the tendons have high tensile stiffness and they respond to progressive tensile loading. And they are very slow in terms of their vascularity, so they have poor blood supply. The ligaments are passive stabilizers by virtue of their activity, and they are limited in terms of their healing capacity. And when they have scarring, when the tissues get scarred from injuries, it alters their stiffness. The muscle have high regenerative capacity and responds rapidly to load. And, its neural inputs. Now, the bones themselves are governed by the Wolff's law. The Wolff's law is a law that tells you how loading should happen, and with it you can calculate. It has a mathematical relationship. So it governs the behavior of the bone tissue and the response to compressive and impact loading. So this is critical for expert rehabilitation scientists and for rehabilitation reasoning, because we should never practice or prescribe loading for a ligament the way we would for muscle or the way we would treat a tendon in order to stimulate adaptation, as though it follows the same timeline as muscle recovery, because that is not true. When we prescribe for tendon, mechanically, we have to understand that tendon is designed to transmit tensile force efficiently. It is relatively stiff in nature and then performs best when it is subjected to progressive tensile loading. But because of its slower vascularity and slower adaptation profile, tendon rehabilitation requires patience, dosage control, and careful progression. And then when it is overloaded too rapidly, then tendon may develop persistent symptoms without gross failure. You keep on seeing the symptoms, but you can't see outrightly that it fails. That takes us to the ligament, which is another tissue. The ligament functions primarily as a passive stabilizer of the structures in the body where it is located. So its role is not first generation, unlike the muscles, but it serves as a restraint, as a guidance, because the healing and remodeling capacity are more limited for a ligament, and because scar formation can alter stiffness, ligamental injury often has significant implications for joint mechanics and long-term stability. So rehabilitation scientists must therefore consider both tissue healing and motor control strategies that protect against recurrent instability in the system. And this also is different from when you're looking at the muscle tissue, because muscle tissue differs sharply from the tendon and from the ligament, because it has comparatively high regenerative capacity and then very strong responsiveness. The way it responds to neural activation, the way it responds to mechanical loading is different from how the tissues and the tissues or the tendon and ligaments respond. So that makes muscle highly tenable and trainable, but often highly sensitive to changes in length, velocity, and coordination. So muscle dysfunction is therefore not only a focus problem, a force problem, but also a timing and a control problem in a sense. Now, if you look at bone as another tissue, the bone adapts according to the loading exposure, especially. It adapts according to the compressive and impact stimuli that it receives. If you look at one of my works, I wrote about the loading of weight-bearing joints and the biomechanical consequences. It aligns with what we are saying. And the impact stimuli that we get is consistent with Wolff's law, as noted in the slides. But it also carries a clear failure thresholds because underloading promotes the conditioning, while excessive or repetitive loading may contribute to stress injury. So the bone therefore requires a balance between sufficient stimulus and controlled exposure so that you can achieve the optimum best. But there are injury thresholds and there are functional implications and consequences for those. And one of the most important or useful ways to teach the model is to really connect the stress strain model to injury models, and then to function, to examine the functional consequences in that mode. So when tissue is loaded below the adaptive threshold, something happens. It normally results to inadequate stimulus. Because there is inadequate stimulus, that tissue will decondition and persistent weakness will result. When tissue is loaded within the adaptive zone, the result may be remodeling or improved tolerance and then restored function. But when tissue is repeatedly loaded near or beyond the injury threshold, then that may result to pain or microfailure or result to instability ahead of movement compensation and performance bias. This in itself is where stress strain model now becomes clinically alive, because tissue failure is not just a microscopic event that occurs somewhere in one cell or in one tissue. No, it speaks to changes in function. A tendon near failure tolerance may show reduced energy storage and then poor propulsion. A ligament with altered stiffness may permit abnormal arthrokinematics and then instability all over the place. Now, a muscle working outside optimal length or speed may fail to generate needed force in time. A force or a bone under a repetitive overload may tolerate daily tasks less and less until pain or fracture occurs. In all of this, the clinical question is never only is the tissue injured, it is also what is the functional cost of this altered biomechanical status or biomechanical states. So when you come to muscle force length relationship, you see that we have captured in the text, in the slide, that as we begin with force length relationship, we state clearly that muscle generate maximum force at their optimal sarcoma length. And that's why when I spoke about what happens when you wear a shoe, the maximal force that a muscle should generate should happen is its natural resting length. But when you wear the high heel, you limit that. So the maximum, the force length relationship is altered. Is the maximum force we generate from muscle will always occur at the optimal sarcoma length. And we need to note that the weakness at long length, such as in extensors, in deep flexion, they may elevate injury risk in those instances, and therefore are often overlooked, in our testing. This is a very important concept for rehabilitation specialists because it explains why muscle performance is position dependent, and muscle does not just produce the same force at every joint angle. There is an optimal range in which the overlap between contractile elements allow maximal force production. When the muscle is excessively shortened or excessively lengthened, force capacity declines, and you need to know this. So clinically, this matters in at least 4 ways because it affects testing. It affects testing. A patient may appear strong in one range, but weak in another one. So if we only test in mid-range, we may miss functionality that may be relevant when we consider deficits. Second, it reflects exercise prescription training, exercise prescription issues, because training at one muscle length does not fully guarantee competence across all the other muscle lengths. So range-specific loading may therefore be necessary. Third, it reflects injury risk because tasks that demand high force at long muscle lengths, such as deceleration, landing, or deep hip and knee flexion tasks, they may expose weaknesses that shape or, have these simpler testing misses occurring. The fourth one is that it affects functional transfer because a patient may perform well in the clinic under constrained conditions, as it were, yet they fall into real life tasks that demand force at different muscle lengths, in which case it gets stuck. So for expert rehabilitation in Nigeria, this is particularly relevant in sports injury rehabilitation and neurorehabilitation. And we see it's relevant in musculoskeletal rehabilitation practices as well, where joint range, where posture, where muscular functional task demands, they vary widely. So now if you speak to muscle force velocity relationship, you will also see that this relationship state that force output decreases as shortening velocity increases. So while eccentric contraction produce the highest forces of any muscle action and are therefore essential for deceleration and holding task, it also shows that and notes that isometrics are usually useful in in very early rehabilitation when motion is painful, when motion is restricted, with progression to maybe eccentric loading happening as healing advances. So you start with isometric, progressing to eccentric when healing only have happened. Concentric force and velocity becomes therefore an interesting area to take a look at because when a muscle shortens rapidly, it produces less force. This means that fast concentric tasks may feel difficult, but only because of coordination demands. But, because the muscle's force generating capacity falls as velocity increases, and that is what it is. So when you look at concentric muscle contraction, as velocity increases, it will fail. The velocity of contraction increases, it will fail. But if you look at eccentric force capacity speaks to those eccentric contractions that allow the highest force production. This is why eccentric training is so valuable in deceleration, in control, in tendinopathy rehabilitation, in landing, in mechanics, and in injury prevention. So in those are areas where we emphasize eccentric muscle contraction, and it is very, very effective because it is based and rooted on sound biomechanical principle. It also means eccentric loading can be highly demanding and must be introduced with appropriate progression in mind. But then if you look at the isometric role, you will see that isometrics are valuable in early stage rehabilitation where movement is painful and where movement is restricted. However, isometric loading can provide early stimulus, pain modulation. It can also provide activation without large joint extension, actually. Now from a clinical standpoint, the force velocity relationship now teaches us that contraction type is not a minor detail. It is a core prescription variable. So experts should deliberately select isometric, concentric, or eccentric work according to tissue stage, according to functional goal, and then according to movement demand. So you should be able to go further when you are making your prescription to capture those nuances so that we know whether you have deliberately selected isometric, eccentric, or concentric muscle work and why those apply. Now, muscle function must always be interpreted mechanically. That is important because when you interpret them, importantly, most synthesis from the session is that muscle function cannot be understood in isolation from mechanics. And that is a fact because if you take a look at the slides, it will show you the link between muscle mechanics and exercise prescription and clinical rationale. Warning against prescribing exercises that does not identify the mechanical reasoning behind them in that context. So this is what we need to always capture. An excellent principle is that muscle weakness is not a generic problem. We must always ask question, is the muscle weak at long length or weak at short length? Is the problem force generation or timing or coordination? Does the deficit appear under fast or slow conditions? Is the eccentric control impaired? Is the joint failing because of tissue tolerance? Is it failing because of neutral tolerance? Is it failing because of task mechanism? It's only when we know this, only then can rehabilitation be individualized. And that is what I want us to consider. There are suggested workshops I will give you in this area. I will also help to prime, and you will see that obviously in your notes, in your slides, and I hope that it helps. But these aspects simply focuses us on the effectiveness of rehabilitation and to show us that it depends on understanding both low tissue tolerance and how muscle produces force under different conditions. And these slides also capture that by presenting the strength strain curve as a guide to adaptation and damage, and by linking muscle force length and force velocity principles directly to rehabilitation decision making. So we as experts in this area should always not stop at naming the tissue that is injured, but rather speaking to the issues. We must ask questions. What load produced this problem, and what region of the tissue tolerance has been exceeded? How has that muscle performance been altered by the length of the muscle, by the velocity of the muscle, by the inhibition? And what movement consequences now follow as a result of that? So can also ask what form of loading will restore function without really pushing the tissue further towards failure. So that is the essence of expert biomechanical reasoning and biomechanical rehabilitation reasoning particularly. So I think that this is an aspect that we need to reflect on and chew on while we prepare for the fourth module. The fourth module, progressively now, we are moving into the modules that speaks more to clinical gait analysis. But the essence, like I said, is to deconstruct the other aspects so that you can easily find the reading in applying the principles that are contained in them in clinical gait analysis per se, and then driving the process with those principles in mind. And I believe that will definitely be a great help. So I have taken module 3 and 4 together for very good reasons. I will try now to look at a little bit of look at joint biomechanics and functional kinesiology, because now we are going into the heart of clinical gait analysis, haven't taken these basics. So I think that you take 10 minutes, we come back and we move into this.
Hello, Mr. Fatai. I can't hear Prof.
The prof is
Hello?
going to come.
It's on
Prof is
break.
coming back. He's on break. He'll come back in the next 15 minutes. Then after that, I think that's
Yeah.
the last module
Okay,
for the day.
okay.
He will
So
come back in the next 15 minutes, and then we'll take the last module for the day. Then we'll meet again.
yeah,
I think we have another lecture on Monday. But I don't know. We'll communicate to you on that, and then we'll know how to go about
yes,
that. And then,
what I'm saying, like I told you, there is another workshop
yeah, we are going to end before the time. We are going to end before.
by 4.
Yes. We're working towards
This
that.
thing we can wrap off before 4.
Yes.
Okay, thank you very much.
Yeah, we just want to actually, Prof wants to establish the basis of gait analysis before we can actually move into the gait analysis proper.
Okay, thank you.
Yeah, thank you.
Hello, please. Which workshop? Is it today? I thought the next one will be on Monday.
No,
That's
it's not.
another stuff for
It's not
this.
regarding. It's not regarding this train the trainers workshop. It's something else because this is the link we are using belongs to the foundation. So there are other activities that they are doing with it. So they will do another workshop in the evening by 4. So that's what I'm saying. The next workshop, which will be physical, will be on Monday.
All right, welcome back. In this module, we shall be looking at biomechanics and kinesiology of normal and pathological gait. We have established sufficient ground for us to now go into proper gait discussion. So here, the earlier modules have helped us to establish that rehabilitation is fundamentally about load, about tissue behavior, about muscle function, and joint mechanics. In this module, we bring all of these ideas together now into one very important and clinically revealing human function, which is the human gait. The slides that you see already speaks to, gait as a repeatable, as a rhythmic or harmonious whole body strategy. No part of the body is left out for forward progression. So it is a cyclic. That is why we say it is repeatable. It occurs in cycle. It is rhythmic. It has harmony. There is proper sequencing of timing and coordination of the body parts in its execution. And it all results in a whole body, it results through a whole body strategy for forward progression, because it always results in translatory motion from one point to the other. And all of these must simultaneously satisfy stability, satisfy mobility, satisfy energy economy. So all these whole body repeated cycles, rhythm and harmony and strategy that drives a forward progression must occur simultaneously to satisfy the requirements of mobility and, of course, stability, and finally, energy economy. You see, I'm very deliberate in starting with stability, then to mobility, and finally, energy economy, because this is how the system progressively thinks about it. So it also describes walking itself as a controlled fall. You see, because that walking, that translatory motion of the body from a point A to a point B in a straight line, which comes in form of bipedal locomotion or walking as it is in human being, it's a controlled fall, because once you take a step forward to walk, you push the body center of gravity outside of the base area of support, and that displacement causes disequilibrium, which increases the tendency to fall. And then the body system begins to recalibrate the neuromuscular activity to bring back this center of gravity, this center of gravity into the base area of support again, by moving the limbs forward and making a contact with a supporting surface, and that provides that the displaced center of gravity now falls within a narrow range of base area of support, and that automatically controls that fall and means that fall will not happen, even though walking by taking a step have initiated a critical element that will warrant a fall. But then the very robust neuromuscular system also advances the limb and places it ahead of the body center of gravity, bringing it within the base area of support and therefore preventing a fall. And that is why we always speak to gait as a controlled fall, or walking as a controlled fall, in which the whole body center of mass, moves forward, while the limbs alternately provide support and then propulsion at the same time. So this is an excellent starting point for us when we now discuss human walking, because it reminds us that gait itself, or human walking, is not simply movement of the legs. It is the integrated output of the musculoskeletal, of the neuromuscular, and sensory systems. The three are integrated in it. So it's not just a main movement of the legs. No. Remember, walking is a translatory motion of the body, but gait is the pattern of walking. It is different from walking. Walking is the translatory motion of the body that enables us to move from a point A to a point B in a straight line. However, gait is the pattern in which that walking is conducted. And that shows a unique feature. It always represents a unique signature, a unique neuromuscular signature, or a unique musculoskeletal signature, or a unique sensory signature that is common to a specific individual, such that you can always tell who is ahead of you, even in that place, by merely seeing the shadow of the person's motion. Even when there is no light, you say, "Ah, this person moves like Leko, this person moves like Audu, this person moves like Sayudu, this person moves like Obi," because of the way he walks. I have not seen the face, but I can tell you for sure that this person is Shehu. And that is it. And you'll be correct. Why is it so? It is so because there is an integrated output of musculoskeletal, neuromuscular, and sensory systems in order to drive that process. Therefore, human walking is a neurally driven process. And one of the hallmarks of a neurally driven process is that there is harmony. You can reduce it to equation. There is consistency. There is a cyclic periodic, repetition. And so for rehabilitation experts in Nigeria, Gait is one of the most important clinical windows that we can have, that we can utilize, because it gives us opportunity to identify primary impairments of movement and then secondary compensations that arise because of that primary impairment. And finally, the movement inefficiencies that persist as a result of it, even the balance threats that may likely be associated with it, and functional capacity diminutions or functional capacity changes that may also arise. Often without sophisticated equipment, we can make those inferences in a very objective manner. So whether we are actually managing stroke patient or osteoarthritic condition or peripheral nerve injuries conditions or Parkinsonism syndromes or spinal conditions or sports injury or post-operative recovery, Gait will always give us immediately a very useful biomechanical information on what to do and what the situation that warrants that situation, what the underlying situations are. So this model therefore really asks a very simple but clinically powerful question. When Gait changes, what exactly has changed? When Gait changes, what exactly has changed? Is it the force of movement that changes? Is it the muscle timing or all the three? What really changes? So the aim of this short model is just to explain the kinematics and kinetics of gait, interpret the ground reaction forces and muscle activation patterns that are associated with it, and then analyze some compensatory gait strategies in pathology, and then apply some of these concepts in a video-based gait analysis system, and then muscle function workshop that we follow shortly. So this model also includes an individual gait and movement analysis report as a continuous assessment that will drive your understanding of this, that will measure and gauge your understanding of what we are doing. I have roughly like 15 minutes more, so I will try and see if I can capture the key elements of this before your next lecture commences using the same platform. So let's also look at Gait as a whole body biomechanical strategy. If you look at the slides, you will see it introduces Gait as a repeatable and a rhythmic whole body strategy for forward progression, which is understandable. And balancing three comprising demands is what happens while this forward progression occurs. As the forward progression occurs, we are balancing the very key important demands for stability, demand for mobility, demand for energy consumption, energy economy, or energy efficiency. So we note, if you take a look at what we have said so far, that small changes in trunk alignment, or small changes in pelvic control, or small changes in the foot placement that we make, they can all significantly alter the stability and the loading pattern of the muscles and the skeletal structure. So this is very important because for an expert in rehabilitation practice, you need to remind ourselves that gait should never be reduced to just foot placement alone or leg movement. No, walking is much more than that. Walking is a coordinated system behavior. It's a coordinated systems behavior. A lot of systems are important applied. Are integrated, including the neuromuscular, musculoskeletal, and then the sensory systems. So it depends on the interaction of postural control, joint motion, force transfer, muscle timing, sensory integration, and mechanical efficiency, because these are the demands of it. Because remember, I told you that while moving forward, you have to balance that need with specific demand for stability, for mobility, and for energy consumption efficiency. So clinically, it simply means that any gait that is abnormal in its pattern is rarely a random deviation. It doesn't just occur randomly. Whenever you see any gait that is abnormal, there's no random deviation in it that just occurs haphazardly. No, it is usually an adaptive strategy produced by some combination of weaknesses, of pain, restricted range, impaired motor control, altered force generation, or fear. All of these are responsible when we see a gait deviation. It's usually an adaptive strategy in response to something. And those things that it responds to may include fear of falling, may include pain, may include weaknesses of muscle, may include restricted range of motion that is required to absorb the shock, probably at the impact of the feet on the ground at the initial response or initial contact, or impaired motor control, as the case may be. So for rehabilitation experts, when we talk about gait, we talk about the functions that pertain to walking as both an assessment tool and also as a reasoning framework, because we use it to assess the integrity of the neuromuscular system, musculoskeletal system, and sensory inputs. And we also use it as a framework to reason about the interventions we are about to provide and what those injuries may have resulted to that demands our intervention, especially when we have to balance progression with stability, mobility, and of course with energy economy. So the aim is not simply to describe what looks abnormal, and that's not what gait does when we are dealing with gait deviations. No, but to determine what mechanical and neuromuscular problem is driving that deviation, because it doesn't happen haphazardly. So we don't just want to describe what is abnormal. We want to know what is driving it. What is the mechanical, deviation, derangement that is driving it? What is the neuromuscular problem that is driving it? Because that is what is key. What neuromuscular problem results in this deviation? What mechanical challenges result in this deviation? When we have a sense and a grip of it, then interventions we make will be based on sound clinical reasoning and scientific principles. Now the gait cycle itself provides the organizing framework for us to really have this sort of rehabilitation reasoning. And so if you look at the strides, you will see the gait cycle as we have put it up there, as the interval from one initial contact of a foot to the next initial contact of the same foot. That is to say, gait cycle consists of all the activities that occur when one foot comes in contact with the ground for the first time, and until the same foot comes in contact with the ground a second time. So if you are walking, you will see there is a time you slap in, or you put down your first foot, your right foot, and then you raise it up again, you put it down again in the second as you advance in your progression. So all the activities that have happened from the very first time that right foot make contact with the ground, and until it makes contact a second time, and that is a complete gait cycle. So a gait cycle comprises of 2 steps. That is the implication. So if you take a look at that, you will see that a gait cycle is divided into 2. The stance phase, which is 60% of the entire gait cycle, and the swing phase, which consists of 40% of the gait cycle. The stance phase is that period in the gait cycle when the foot, either one foot or both of them, are in contact with the ground. Whereas the swing phase is the period where the foot is swinging, at least one foot is swinging in the air and not making contact with the ground. It consists about 40% of the entire gait cycle. I want us to clearly understand that the stance phase, which we describe as the period when one or two feet, when one or both of the feet are in contact with the ground, that stance phase is divided into subphases. It's divided into 5 critical subphases. The first one is initial contact. When the heel, the foot makes contact with the ground, it can make contact with the heel, make contact with mid zone of the heel, and so on. Then you have the loading response. The moment you make contact, there's a loading response. Because once you make contact, the external forces that drive that contact triggers a ground reaction force. You see? And that ground reaction force acts in the opposite direction and produces a compressive force that squeezes the proximal joints of the body. There is also a gravitational force field under which you are working, which drives the whole system towards the center of Earth and towards collapse. So there is an external force that demands an internal response by generating, forceful activities to support the body structure in the vertical sense on the resolution component, or to drive the progression in the horizontal component, or backwardly to break the system as you advance, so that there is some kind of control also. So you see that there is a loading response that occurs initially. After initial contact, there is a loading response that follows. And then you have the mid stance. That mid stance is that part of the body, that part of the gait cycle, when one foot is in contact with the ground and the other one is just adjacent to it as it swings past by. So that point where the left and the right are almost juxtaposed against each other, but with one of them making contact with the ground, is the mid stance. The terminal stance occurs immediately you move from mid stance, you enter the terminal stance. And it ends with the praise swing, where the body adjusts itself to swing again into, swing the foot again into the air. And then it now moves from praise swing into the swing phase completely, where the foot is swinging in the air without making contact with the ground. And that swing phase is divided also into 3: initial swing, mid swing, and terminal swing. So this structure is just essential because, gait analysis becomes much more precise when they are tied to phases. And so we can understand what happens in each phase without having to, without having to get confused about where exactly and what exactly we are looking for and where what has happened. So a movement or a force problem must be identified in relation to when it occurs. So we need to know, when did this force problem occur? When did this movement problem occur? Did it occur at initial swing? Did it occur at mid swing? Did it occur at terminal swing? Did it occur at loading response, or initial contact, or mid stance, or terminal stance, or pre-swing? We need to know where it occurred the first time. So when you are simply trying to identify the problem of force or problem of movement, you have to determine this in relation to when it occurs. So a patient who shows reduced knee flexion in loading response presents a different biomechanical problem for one who lacks knee flexion in swing. So if I say that this patient has reduced knee flexion, but this reduced knee flexion happens only in loading response phase of the gait cycle, it is going to be different from somebody who also has knee flexion limitation in swing. They have two different issues. So that's why you tie that thing you observe, that movement dysfunction you observe, that aberration in movement that you have observed or force problem that you have observed, you must tie it to the specific phase of gait cycle. So if you don't know the 8 phases of gait cycle, how then can you tie any of these? Because each one, presence of each one in each cycle speaks to a different thing. So as expert audiences, we need to really look at the main teaching point here, and that is that phase-specific reasoning turns gait analysis from observation to diagnosis. That is something we must not forget. Phase-specific reasoning turns gait analysis from observation into diagnosis. I will take the kinematics of gait in the next 3 minutes, and then I will stop at that. We will continue subsequently on Monday. Now, kinematics speaks to description of how the body moves in terms of position, joint angle, joint displacement, velocity of motion, without referring to the forces that actually cause this movement to occur. So when we are talking about kinematics, we have no interest in the forces that produce the motion, but we have interest in the motion that is produced. So it also identifies the key spatiotemporal parameters, such as the step length, the stride length, the cadence, the walking speed, and the stance or swing ratio. We look at nothing, we look at also the asymmetry in these measures as providing signals around pain avoidance, weaknesses, or neurological impairments. The most important thing for us is that this area, if you look at the slides, it gives you a typical insight into joint kinematic, the joint kinematic patterns across gait cycle. It tells us, for instance, that at the hip, about 20 degrees of flexion occurs at initial contact. So if at initial contact you use your Kinovea, you can actually see it, that there is 20 degrees of flexion at the hip. If you progress towards extension in stance, then flexing again in swing continues, and then you move to the knee, you see that there is near extension at initial contact, controlled flexion in early stance and extension in mid stance, and then substantial flexion in swing for clearance. If you come again to take a look at ankle, what happens through the gait cycle, you will see that there is near neutral ankle position at initial contact. Then it goes into dorsiflexion during stance, and then into plantar flexion for push-off. So this is the normal movement template against which pathology can be judged or pathology can be assessed. Clinically, once you have altered kinematics, it reflects one thing. It reflects that there could be pain, there could be weakness, there could be joint restriction, there could be spasticity, could be poor timing or compensation. But the expert challenge here is not merely to notice that there is any of this alteration. The challenge here is to determine why it is altered and what functional cost follows from that alteration, and which is what you will have to address. In a subsequent discussion on Monday, we look at the kinetics of gait, in order to understand why the body moves the way they move as a result of the forces that apply to them. So I take any question that is critical, before I exit for the other lecturer to continue. Any questions?
Prof, we have some questions on the chat box.
Can you read out some of them, please? Just one of them, because this is already 3:55, and the require it is 3:56 now. I have to exit in 30 seconds. Yes.
Thank you, Prof. This is advanced. This is advanced. Talking about moments, it is essential to move a joint through its full range, thereby activating the whole muscle fibers involved with moment arm, range in short change, and some muscle fiber too. How do we address this? I come again. It is essential to move a joint through its full range, thereby activating the whole muscle fibers involved with the moment arm. Range is short-changed, and some muscle fibers too are short-changed. How do we address this?
Well, if I understand this, you need to move the muscles, the joint through a full range, so you can maintain the competency and integrity. But when you have an injury, you don't do that. You do it slowly. The idea is that you need to understand the implications of loading too quickly. So you need to understand the behavior of the tissues when they are injured. Remember, the patients coming to you are not normal. So you can't, ascribe what happens in normal situation to patients. So what we are trying to say is that don't treat patients as you would treat normal human beings. Treat them as those who are recovering, but you need to understand the behavior of the tissue so that you can know how to load the tissue, how to treat it, how to apply this movement. Otherwise, you cause more injury. So I recognize the need and the fear that we may have limit, not use the whole range of fibers when we limit the graded progression. It's a progression. We progress to the full length, but we go step by step. Eventually, we will reactivate everything, but one step at a time as the patient makes recovery. That's why it's called recovery. So you give what is necessary to make sure that you recover without constant damage. If you can take all the questions and write them down, I treat them on Monday. So I leave you here in order to give room for MRTB to continue with the other processes. So thank you so much. I'm so sorry for the time. It's always like that. I'll see you on Monday. We deal with all the questions. Have a blessed weekend. MRTB, over to you.
Thank you very much. Thank you so much. We really appreciate your time and your expertise. So I think since the reason why we are rushing to finish is because there is another workshop that will take place was almost the same link. So, and it's starting by 4. So we are very sorry for any inconveniences. So we'll see on Monday to continue the workshop. I don't know if the registrar is around. Let me check. If he's not around, then we can just call it a day for today. So the registrar is not around. I think we can call it a day. For anyone that wants listen to the program, you can just, but I will ask for the link, but you can just search for Clinical Pathway on YouTube. You will see the series of clinical pathway workshops. Then you click on anyone you want to watch again. Then that is it. Thank you so much. Bye bye. See you on Monday.